It's definitely my pleasure to introduce our host, Dr. Jason Lichten. Thank you, Jason, for being here. Let me give you a little bit of background about Jason. In 2009, when his son was born, Sam, or actually not born, when he was 7 years old, Sam was diagnosed with psoriasis. And Jason and his wife, Rachel, wanted to understand what the diagnosis would mean for Sam and their family. And lo and behold, they found the NPF, and as they say, the rest was history. And in 2011, Jason and Rachel began organizing the 5K to cure psoriasis in Columbus, Ohio. The first event brought 180 runners to the start line. The second year, there were 250 runners, and it continued to grow over the years. And to date, the 5K to cure psoriasis has raised over $200,000 and significantly increased awareness of psoriasis in their community. Dr. Lichten was elected to the NPF Board of Directors in 2015, and he continues to serve today. A plastic surgeon, Dr. Lichten is the founder and director of Central Ohio Plastic Surgery Incorporated, and his family includes Rachel and their 3 children, Sam, Jake, and Sophie. So welcome, Jason. We're so thrilled to have you here.
And there we go. Sorry, no, thank you. I'm happy to be here. Happy that the timing worked out. For those of you in the East, hopefully you're having this beautiful weather that this second summer that we have here now. So, but I've been very honored to be a part of the National Psoriasis Foundation and to be able to be here today. So I'm excited here to introduce 2 people who I have the distinct pleasure and honor of getting to work with. Both Ron Grau, who's the director of the president of the chairman of the NPF Board of Directors, and president and CEO Leah Howard. Ron's been active initially with the South Florida division since 2001, came on the board in 2014, and currently is serving as the chair. He has psoriasis and has worked with NPF staff, healthcare providers, and other people living with psoriatic disease, local, state, and federal initiatives. Successful business leader and father. He's married, has 2 daughters, and lives in Windermere, Florida. And there is no better person who I could think of to be the chair of the board. I'm honored to get to serve with him. Leah Howard, JD, joined the National Psoriasis Foundation back in 2012. Recently being promoted and appointed to the role of president and CEO. Previously served as the chief operating officer, providing strategic direction, vision, and leadership of the foundation's mission-related functions of government relations and advocacy, marketing, communications, and patient services. Prior to that, she directed the advocacy and government. Essentially, she has done it all within the organization, and there's nobody better to lead us into the next steps. Aside from her choice of football teams, there's nothing I can say bad about her, but I'm honored to work with these 2 people, and I'll turn it over to them to tell you a little bit more.
Great. Jason, thank you very much for that introduction. I appreciate it. And I want to say on behalf of the National Psoriasis Foundation Board of Directors, including some of my colleagues who are also joining us today, I want to say welcome to the final NPF Community Conference of 2022. As you've heard by Jason, my name is Ron Grau. It's my honor to be the chair of the Board of Directors. Our theme of today's conference is Healthier Together. It's more than skin deep. And as I reflect on themes for each of the 3 conferences this year, Healthier Together, Celebrating Our Differences in March, and Healthier Together, Learning for All Ages in April, and then today's conference, Healthier Together, It's More Than Skin Deep. It's really such a demonstration of the important role of the National Psoriasis Foundation plays in serving individuals living with psoriasis and psoriatic arthritis. Today's theme in particular really speaks to the significant burden of living with a diagnosis of psoriasis. Of course, with this is something all of us with psoriatic disease knows well, but I think many who aren't impacted by psoriasis or psoriatic arthritis really don't understand. My own experience with psoriasis started back in the early 2000s, where I went from having a little patch here and there to being full-blown with psoriasis. At the time, I didn't even know about the National Psoriasis Foundation, and after a simple Google search, there it was. Lucky for me, there was a conference similar to this one scheduled out 2 weeks, and I immediately signed up. And that was actually, out of all the conferences I've attended in my life, I would say that one in particular was the most life-changing conference I've ever attended. There were dermatologists, there was a dermatologist there, there was a rheumatologist there. I got to ask a lot of questions. I got to learn about the disease and ultimately get on the right track towards getting clear. So after all these years, since then, getting all that knowledge, getting on the right treatment, I have been clear with psoriasis for many, many years. Great success. I also have psoriatic arthritis, which is again, has helped my psoriatic arthritis as well. So really great success story, and a big thanks for the National Psoriasis Foundation, which is again why I'm so involved in such a great organization. So you can see why I'm happy to be here and learn alongside all of you today. As we kick off the conference, I want to just reflect for a moment on the NPF as we race towards the end of 2022. This is an incredibly exciting time for the organization because we've just crossed the halfway point in our current 5-year strategic plan. Hopefully you've heard about some of the exciting developments at the foundation in recent months, including in September, the NPF started the second year of a 3-year grant from the Centers for Disease Control and Prevention. Also in July, the NPF announced the $3.2 million in research grants and fellowships. And in June, we announced we had selected Leah Howard to be our next president and CEO of the NPF. As I've gotten to partner with Leah over the last year, first as interim president and CEO, upon Randy Baranik's retirement at the end of 2021, and now as our permanent president and CEO, I can say that it's clear she's definitely the right woman for the job. No one works harder than Leah, and her passion for the NPF is to be admired. From my perspective as chair of the board, the future is incredibly bright for the NPF. This is really a new chapter for the National Psoriasis Foundation, and we want to engage each of you as we pursue the mission of the NPF. I'm going to turn it over to Leah now, but just want to conclude my welcome by expressing how much we appreciate you joining us today. I also want to thank the entire NPF staff because I'm incredibly thankful for the fact that we have a National Psoriasis Foundation consisting of people that actually wake up every morning, go to work, and are actually getting us one day closer to curing this nasty disease every single day. I'm also incredibly thankful for the growing number of volunteers that offer their time selflessly to help meet our important mission. Thank you, and have a great conference. It's with great pleasure that I introduce our brand new 3-4 months now, Leah Howard, our president and CEO.
Thank you, Ron. Thank you so much for your kind remarks, and thank you to Jason too. We could argue about football later for sure. Always enjoy a good football debate on a Saturday in the fall. And I want to thank both of you for being here and for your leadership and the leadership of the rest of the board of directors. We have an amazing board of directors at the National Psoriasis Foundation, and everyone who's involved in the board has some personal connection to psoriatic disease, either as you've heard from Ron's story, either by living with it themselves, or Jason's story being a parent, or being a clinician, someone that treats individuals with psoriasis and psoriatic arthritis. So I think we're all very fortunate to have each of them and their expertise helping to guide and support the organization as we advance into this new chapter that Ron mentioned. You know, there certainly is a lot to do at the NPF, but as you heard from Ron, I think we have an amazing group of volunteers and staff who are working tirelessly in support of the mission. And I have full confidence that through that partnership and engagement, we will get to the goals that we have. I also want to second Ron's comments about the excitement he has for today's theme. I too share his interest in the topics that we'll be discussing today. And as you heard Ron mention, we've had a lot of great news come out of the NPF over the last year. But we've also shared some information that I think is not so good that I want to highlight right now, because I think it really speaks to the importance of today's conversation. Back in August, we issued a press release sharing some new data that the NPF had gathered through a survey in June. And the headline of the press release, I'm going to read off my notes so I get it right, is "New data shows Americans overwhelmingly stressed, posing a threat to the 8 million living with psoriasis." And if you take a look at that press release, which is up on the newsroom section of the website, we'll drop a link in the chat. What you will see is that we share data in that release that we gathered through this survey, which found 1 in 3 individuals living with psoriasis report that they are depressed. So I think it's really evident why today's conversation and the experts that you'll be hearing from today are so important for us to be bringing to you and to others in our community. As we write this new chapter at the National Psoriasis Foundation, the work that we are doing really goes so much more beyond just trying to support each of you as you address the issues that you're experiencing with the psoriasis that's presenting on your skin and the arthritis in your joints. Because we know that when you live with psoriasis like Ron does and like I do, there's so many more elements to managing the disease than simply thinking about the skin and joints. And so that's what we're trying to do at the NPF every day, is really support each of you and the other members of our community on your journey, to get you to a place where your burden of living with psoriasis and psoriatic arthritis are significantly reduced. As you heard from Jason and Ron, it's really been my pleasure to be a part of the work of the team over the last 10 years that I've been at the NPF. And while I've had a chance to work in a lot of different areas of the organization, I think what's been most fun for me has really been the opportunity to connect with many, many members perspective or education programs like today's conference, or even some of our marketing efforts. My greatest joy is really getting to engage with individuals in our community, supporting each of you, giving you tools and resources and helping you feel more empowered to better manage your disease and to have the conversations that you need to have, whether those are with your clinician or in your workplace or with your family or caregivers or friends, to help you get to a place where you feel good, head to toe. And we know that despite the many advances in our space over the last 20 years in particular, there's still many, many members of our community that are struggling. And so we are committed to working every day until we get each and every one of those 8 million members of our community to a place where you're doing well. And of course, a cure remains our ultimate goal. So as we engage in today's discussion, please know that the NPF is your resource. You heard Jane talk about the chat. I know the chat is one of the most exciting elements of these conversations, because you can share questions in real time, and we will work to provide you lots of links and resources through the chat as well as through the live conversation. So please definitely take advantage of that. I will try to listen and contribute here a bit as well. And I just want to end by saying what a privilege it is getting to come in to work every day to really advance work for a community that I am a part of, and I know has really seen a lot of progress and yet still needs many, many more things. So thank you for joining us at this session. Thank you for being a part of this conversation. And with that, I'm going to turn it back to Jason. And
all right. I think I may, hopefully I got the video up right, working better. No, I don't.
we can see you, Jason. Yep. It was better a minute ago, actually. Turn that off. There you go. No,
yeah,
now we lost you.
Is that? I'm running on 2 screens. That's the problem. I'm running through my phone because I do apply. My daughter had cross country this morning, so I had to like run around to get that to work. Can you hear me now at all or no?
Yes, we can hear you, Jason.
Gotcha. Okay. Sorry.
That's okay. So Jason, before you introduce the next speakers, we have a short poll we'd like to present to the attendees, all the attendees here, just to get a feeling of how do you feel? It's going to be an emotional health check-in. So let me go ahead and start this up here. And it's just got, I think, 4 short questions. So we really appreciate you going ahead and taking them. So can you see the poll now?
We can.
Oh, good. So please go ahead and answer those questions. We'll give you a couple minutes and then I'll let you know when I'm getting close to ending the poll. I see a lot of good answers coming in. Give it just a few more moments here. It's good. I'm keeping it open a few more minutes. We got a couple more people that just gave us their answers, so thank you. All right, looks like that's about it. I'm gonna end the poll in 3, 2, 1. Thank you all for participating in the poll. So I'd like to go ahead and share the results of this just before we introduce our next speakers. And this is the first time I've done a poll like this. So can you all see the results here?
We can, Jane. Yep.
Leo, thank you for being my voice. I appreciate that. All right. So in the first question, wanted to know which of the following have you experienced regarding your psoriatic disease? And it looks like the top 2 answers were overwhelmed with treatment or care needs and trouble sleeping not associated with pain. And then pretty much evenly split between anxious, being around other people, depressed, embarrassment about how my skin looks. And interesting enough, stress over going out or choosing not to go out was one of the lower answers. Number 2, how self-conscious do you feel about your psoriasis? Somewhat, depending on how visible my plaques. That 50% of you answered that, and a great 22% said not at all. That's wonderful. 6% answered always cover my plaques to avoid discussion, and for a few of you, not applicable. Good to see that no one answered distressed by my plaques and never go out. I love that. And then for number 3, true or false, I love myself. A whopping 89%. Yes, we agree with that. And then I feel flawed, true or false. Here we go, 56% said true and 44% said false. So wonderful insight into all of our attendees today. Thank you so much for taking this, and I hope Dr. Freed and Dr. Cutler will be able to provide some good insight for you. So Jason, would you like to go ahead and introduce our next speakers?
Absolutely, I'm happy to do that. So I have the pleasure now of introducing Dr. Freed and Dr. Cutler, who are going to talk to us a lot about some of these issues, obviously related to stress. Dr. Freed is the clinical director of Yardley Dermatology Associates and Yardley Clinical Research Associates in Yardley, Pennsylvania, out of Yardley. He's internationally recognized clinician, researcher, and teacher. Dr. Freed is also a member of the National Psoriasis Foundation's medical board. Thank you for participating there. Dr. Freed has the unique distinction of being both a dermatologist and a clinical psychologist. His compassion and experience in psychodermatology offers a distinctive look at what may drive the connection between psoriatic disease and mental health issues such as depression and anxiety. Dr. Vanessa Cutler is a psychiatrist with clinical practice at NYU Langone Health in New York. Additionally, Dr. Cutler is a clinical assistant professor with the Department of Psychiatry at NYU Grossman School of Medicine and the medical director of behavioral health at Four Winds Hospital in Saratoga Springs, New York. Dr. Cutler is a contributing author to, actually ordered this week, Essential Psychiatry for the Aesthetic Practitioner, where Dr. Freed is a book editor along with Dr. Reeder. She addresses the science and psychology of beauty. The purpose of this guide is to help practitioners with the assessment and identification of psychiatric diseases and offer tips to help with obsessive compulsive and body dysmorphic disorders associated with skin diseases such as psoriasis. Dr. Freed and Dr. Cutler are here to talk about our state of mind, how to overcome emotional challenges like anxiety that impact people living with psoriatic disease. So with that, I will turn it over to you guys.
And Dr. Freed, I'm going to go ahead and stop sharing, and if you'd like to share your screen.
Thank you so much. Can you all hear me?
Yes, we can.
Wonderful. First of all, I want to so very much thank Ron and Leigh and Bev for all the work that you tirelessly do, and Jason as well. I want to thank everybody who has tuned in. And for the past 25 years, what I've been privileged to learn from every psoriasis sufferer that I've worked with. I will say, as we begin, that there's never been a more exciting time on this planet to have psoriasis. And forgive me for that segue, but honestly and truly, we're living in a revolutionary time right now where virtually 99% of people with psoriasis can get wonderful control over their psoriasis to the extent that they choose. And I'm going to try to convince you of that in about the next 20 minutes. And Jane, do we have our slides?
Yes, do you want me to share them? I wasn't sure if you wanted to, or I can also.
If you can show them so we can see them, then I'll be happy to advance them.
You won't be able to advance if I'm sharing.
Okay, any way I can see them is good. I'd be happy.
Great, I'll share and then you tell me when to
I
advance.
got it. And so next slide, if you would. And moving on, yes. Yep. And what we're hoping to achieve today, what are we all going to learn? The impact of stress and living with a lifelong skin disease that has a genetic risk. Number 2, signs and symptoms of anxiety, how to cope with the stress and anxiety, tips for building self-esteem and acceptance of living with visible skin disease, and when a referral to a mental health care provider is indicated and helpful. Next slide. So I'm just going to ask you to move for 3 slides forward because these are Dr. Cutler's. One more. Good. So I want to start talking, if I may, about the Diagnostic and Statistical Manual of the American Psychiatric Association, the godfather, if you will, or godmother, telling us how we know if a person has a certain psychological disorder. So when they talk about signs and symptoms of classic anxiety, feeling nervous, on edge, overstimulated, panic attacks, a strong sense of impending danger, death, and doom, sensations of weakness or fatigue, rapid or irregular heart rate, uncharacteristic irritability, feelings of guilt and hopelessness, restlessness, jitteriness, hyperventilation, muscle tension, or twitching. Now, I believe we just described the entire population on the planet right now. And part of that is it's always been some part of our daily day, our makeup, our genetics, and part of the uncertainty with the world we live in right now. I love a definition of the difference between fear and anxiety. Fear is seeing a lion 2 feet away about to have you for lunch. Anxiety is having the same physiologic reaction, but you can't find the lion. Now, when it comes to psoriasis, maybe we do see the lion, but there are also many, many other things in our environment that are causing stress and distress at this time. Next slide, if we can. I feel that talking about anxiety without talking about depression is unfair because they're so intimately linked, and because we know that psoriasis sufferers, survey after survey after survey, have been shown to be more prone to depressive disorders. So the DSM says in order to be diagnosed with depression, we have to have depressed mood most of the day, nearly every day, markedly diminished interest in pleasure at all, almost all activities most of the day or nearly every day, significant weight loss when not dieting, or weight gain, or decrease and increase in appetite nearly every day. A slowing down of thought and a reduction of physical movement, observable by others, not merely subjective feelings of restlessness are being slowed down. Other people look at us as though we've got a little bit of glue on the bottom of our sneakers. We're just moving much more slowly. Fatigue or loss of energy nearly every day, feelings of worthlessness or excessive inappropriate guilt nearly every day, diminished ability to think or concentrate, indecisiveness every day. And any of us who fall on the ADD, ADHD spectrum, I get that. Recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt. Now, please be aware that this is talking about significant depression. Next slide. I think something that may be more familiar to many of the people on this call or this video is a concept of what I call subclinical anxiety and depression. We don't quite check many of the boxes of the DSM criteria. We don't appear to other people necessarily as being depressed or anxious. So what does happen, though, is it diminishes many of the feelings of happiness and contentment throughout our spheres of functioning. When I say spheres of functioning, we all wear a bunch of different hats all day long. We've got our family hat, we've got our work hat, we've got our social hat, we've got our school hat. And with subclinical anxiety, subclinical depression, we can put that hat on and dance the dance pretty well. But internally, we kind of feel like, can I interact and function to these variable degrees? Do I have to today? This is exhausting, putting on the mask. I feel jangled, disconnected. This is bull, whatever, why bother? So the subclinical is a loss of excitement, loss of enthusiasm. Attribution to, well, yeah, I'm 35, 55, 75. I guess this is what age is. Attribution to the hopelessness of the outside world. How could I be happy with what's going on in the world? Flowers, fruit, travel, sex. Lost its glow, lost much of its appeal. A generalized kind of apathy. Next slide. Now, one of the things I found helpful in assessing a psoriasis person in terms of how much the psoriasis has taken from them is asking them a very simple question. Before you had significant psoriasis, what did you used to do for fun? You'd often hear from people, you know, I like to go bowling, I play tennis, I played volleyball, I love to go to sports events, I went to my kids' softball games. Great. Since the psoriasis has gotten more active, what are you doing lately? Sometimes there's a deer in the headlights kind of stare where they had not realized how much of their joy and engagement psoriasis has taken. Next slide. So self-image, self-acceptance, and perfection. We, as a species, have the unfortunate daily occurrence to look in the mirror and compare what we've got to the social media images of perfection. And we are bombarded with perfect skin, perfect bodies, perfect athletic ability, perfect academic performance. Then we got to look in the mirror and say, that I compare to this how? Then we got fear of missing out, or FOMO on Facebook. And it's not a typo there. We know that Facebook posts, everyone is so happy, so engaged, so full of energy. And our life, we look at, what about us? So there's a perpetual blurring and magnification of our imperfections, psoriasis, and 100 other things. It's a media-driven self-loathing for exploitative gain. So if you take my magic cream, you will look 32 years younger and never have a spot of psoriasis again. And it's almost a sucker born every minute. And we fight that temptation throughout our lives. Next slide. Dirty secrets. This is how we all live our life. We're not good enough, not pretty enough, not perfect enough, not smart enough, maybe contagious, maybe dirty, maybe ugly, maybe sinners. We can go on. If they only knew who I really am, nobody would love me. This is pervasive with every human being. It's been written about with executives called the imposter syndrome. All of us are terrified of exposure. The problem with psoriasis in visible areas, we feel extra exposed. Next slide. As a psychologist, I'm a control freak. Actually, I don't want to control anybody, but I want to sell it. And every psoriasis practitioner, physician, nurse practitioner, physician assistant, nurse, on and on, we are selling control because psoriasis takes away our control. As a graduate student, one of my co-doctoral students did her doctoral dissertation on control and what happens in the setting of loss of control. What she did is she put rats in a cage and gave 2 levers in the cage. Lever on the right gave food, lever on the left gave an electric shock to the grid. The rat learned very quickly which lever to press and which not to press. The rat became, quote, normal, ate normally, socialized normally, sexualized normally. Phase 2 in the experiment, they kept switching the wire. The rat could not predict which lever would give food, which lever electric shock. What they got was an animal model of a person living in an unpredictable environment. The rat became either anorexic or hyperphasic, meaning it would eat everything in its sight, either became asocial or bizarrely aggressive, asexual, hypersexual, often did autistic rocking-like behavior. And in people and in life, and in psoriasis and in life. Psoriasis is capricious. We never know next Friday, will it be a good psoriasis day, a bad psoriasis day? We don't know when, where, how severe, how visible, how long. When we get legitimate treatments, it enhances our self of control. We know as we're getting good treatment, fewer flares, less severe flares, minimal flares, or by National Psoriasis Foundation goals, no flares, no psoriasis. Next slide, please. Solutions. Self-talk. We're all filled with self-talk all day long. As I said, if they only knew, what if this happens? What if I say the wrong thing? Reminders and reminders. We are all perfectly imperfect. And the closer we get to perfect, the more obnoxious, the more repulsive we are to the people around us because it makes them feel worse. We are all limited. We're all pathetic if they only knew. Rodney Dangerfield, many of you are old enough to remember who he was, had a wonderful line. I am so pathetic, even my imaginary friend won't play with me. Be kind to yourself. Seek legitimate care. Seek care that lessens the inflammation and potential damage of psoriasis. I'm going to say that again. Seek care that lessens the inflammation and potential damage of psoriasis. We're going to talk about that. Embrace two helpful benefits of your treatments. Next slide. Psoriasis in Las Vegas. What happens there stays there. We used to think that the inflammatory chemicals released in the skin that make psoriasis grow and get angry. We used to think they stayed in the skin. We know their names, tumor necrosis factor, the interleukins 23, 17, the Janus kinase inhibitors, the list keeps growing. But now we know they don't stay in the skin. They enter the bloodstream and affect end organs, the heart, the liver, the lungs, and the brain. These inflammatory chemicals cause inflammation in the brain. Now, neurotransmitters, every thought, every action, every ability we have is based on these chemicals in the brain communicating. The three big players are serotonin, norepinephrine, and dopamine. These, when depleted, can be associated with anxiety, depression, fatigue, lethargy, all the things we've talked about. So, what do these chemicals do when they get into the brain? They pull down or deplete available serotonin, norepinephrine, and dopamine. So here's the question. We know the associations with psoriasis, with anxiety, depression, etc. So does living with psoriasis cause emotional distress? And is that why we feel sad? or is it central depletion of neurotransmitters in the brain? The answer is probably both, and both can be made better. Next slide. The mandatory comma. We know if we see commercials, whether it's for Tals, Consentix, Tremfya, Skyrizi, Humira, we see these smiling faces, then we see every horrible thing that can happen if you take this medicine. They don't remind us that, as happened 6 months ago in my practice, people can die from a gummy bear. No, not choking on it. I had a patient who took a gummy bear vitamin, had an allergic reaction to red dye number 2, and almost died. So anytime anything crosses our lips, crosses our skin, enters our body in any way, good and bad stuff can happen. So maybe we should get warnings about life at the moment of conception, give a disclaimer warning at birth and every day. But you know what? There should be a mandatory comma required by the Food and Drug Administration that says these are the bad things that can happen if you use or take this medicine, comma. In contrast, the bad things that can happen if you don't take these medicines are the following. So what terrible things can happen if you don't take a medicine? Important perspective when all of us choose what medications to take, what vitamins to take. Next slide. So how do we cope with the stress and anxiety of psoriasis and of life? Now, I want to be very clear about something when we talk about stress and anxiety. And that is that anxiety and stress and depression make any inflammatory condition more likely to flare. Whether it's psoriasis, whether it's rheumatoid arthritis, inflammatory bowel disease, fibromyalgia, sinusitis, anytime the inflammatory system of the body is overacting and overreacting, stress can make it worse, which is a very different thing than saying, oh, if you only handled your stress better, you wouldn't have psoriasis. That's baloney. Because anything that activates the immune system can make our immune system overreact. And let's be clear about one other thing. What psoriasis is in its purest sense is a declaration that your immune system works too well. Not immunosuppressed, works too well. The inflammatory immune system that God and or nature gave us is designed to be the police officer in the body. What does the police officer in the body do? What the police officer in society does. Be on outlook for the bad guys. What are the bad guys in the body? Bacteria, fungus, virus, and cancer. So whenever the immune system thinks there's a bad guy in or on the skin or in the body, it revs up to do battle. Psoriasis is one of the pathways by which the immune system can overreact when it feels jeopardized. So we do not want to suppress our immune systems. We just want to suppress the little twig that's overreacting, be it TNF, the cytokines, any of those pathways, leave the rest of the immune system intact, which is exactly what our modern medicines do. Now, does decreasing anxiety and distress make us less likely to be inflammatory? Yes, it does. So some of the simple things we have listed here: square box breathing. Square box breathing is simply dividing the breath cycle into 4 parts. On the inhale, 2 or 3 seconds, hold the breath 2 or 3 seconds, let it go 2 or 3 seconds, pause 2 or 3 seconds. Just that rhythm of the square, in, hold, out, pause, decreases blood pressure, can decrease release of stress-related hormones, and can make us subjectively feel more in control and more relaxed. Progressive muscle relaxation, just a standardized way of tightening a muscle, relaxing it. Meditation, particularly mindfulness meditation, but it can be any of the meditative practices, have been shown to make psoriasis treatments work better. Yoga, Tai Chi, exercise, any rhythmic activity, music, cycling, examining our self-talk, how horrible or catastrophe this or that is, cognitive behavioral psychotherapy, the best tested, best proven for the management of anxiety, depression, tea, aromatics, National Psoriasis Foundation, and legitimate information sources. Who do you trust? Who do we trust? There's so much information available. And the question is, who's got the legitimate stuff? We know the NPF has one goal and one goal only, to deliver factual, accurate information and advice and be a resource center. Many other things it does. Knowledge is power, power is control, feeling in control diminishes anxiety and depression. Next slide. When to seek help. I'd like to save that. Can we just go back to the last slide for a minute? So I want to talk about inflammation. Many of you know who Cindy Lauper is. And the National Psoriasis Foundation arranged a congressional briefing several years ago where Cindy Lauper and I spoke before Congress because Congress wanted to cut funding for psoriasis. We started the briefing and two senators got up to leave. This was in Washington, D.C., room full of senators and congressmen and their aides. Two gentlemen got up to walk out. And I thought to myself, yeah, I'm 30 seconds into this. I'm a pretty crummy speaker, but if they start a parade, we wasted our time. And I looked at the two guys. I said, you know what? Sit down. I'm here to talk about psoriasis, but I'm here to talk about something a lot bigger. We got a problem on this planet. Our inflammatory systems are wildly out of control. And if we don't get better control of our inflammatory systems, we're all going to be dying younger, more unhappy, and we're going to be a mess and our families will be a mess. And I looked at one of them and I said, I don't know where your inflammation in your body is. It might be your left coronary. It might kill over tomorrow morning. Good for your constituents or bad. I don't know. But we got to get this under better control. And I challenged the group. I said, if one person in here does not personally suffer from or have a family member who suffers from one of the following, please raise your hand. Psoriasis, eczema, rosacea, acne, fibromyalgia, inflammatory bowel disease. The list went on and on. Not a hand in the room went up. So every one of us have unleashed, unmitigated anxiety. So we're all in this together. And it's a wonderful journey right now. It's a wonderful journey because not a week or a month goes by that we do not have another new understanding of inflammation, another new understanding of how to control it safely. COVID took this to the absolute forefront. People who died from COVID did not die from the virus. They died from their own inflammatory system getting wildly out of control. As a result of NPF, as a result of COVID, as a result of the brilliant scientists out there, we are all going to have easier, more effective things in our hands. And if you walk into any dermatologist's office today, you will be shown an array of medications, topical medications, oral medications, injectable medications that can make your psoriasis better. Let's go further. There's study after study that show that treating psoriasis can actually decrease heart disease, can decrease diabetes. Treating psoriasis can make people happier in their relationships. I'm going to stop in a minute, but I want to tell you one interesting thing that happened about 3 years ago. Gentleman came in, 52 years old, with psoriasis, elbows, knees, lower back, little bit of nail involvement where the nails looked a little bit brittle and ridged. And I said, Joe, are you bugged by your psoriasis? Nah, doc, same old crap, had it for 40 years. since 12 years old. I did something that is not a good idea from one guy to another. I held eye contact. When you hold eye contact male to male, you're either challenging him to battle or coming on to him. Sometimes not appreciated in either realm. I held the eye contact and I said, Joe, honestly, how tough is it? Within 2 seconds, head went back and forth, eyes started to fill up. He said, it sucks, Doc. I hate it. I hate it. So I talked to him a little bit about going on Otezla. And Otezla, as many of you know, is midway between a cream and our injectables. And I said, the other thing I'd like you to take is a medicine called sertraline or Zoloft. It's not because I think you're depressed up here. Your skin is by definition irritable and out of control. That's what psoriasis is. So he said, okay, 6 weeks, he came back in with his wife. And his wife walks over to me. I put my hand out and I said, Rick Fried, nice to meet you. She said, yeah, whatever. What's this? And she hands me the bottle of sertraline. And I said, well, by class, it's an anti-anxiety, I got that far. And she said, I don't care what you have to say. I'm going to tell you what it is. It's a miracle. And then she holds up the Otezla. She said, or this one is, because this gave me back a husband, a father, a brother, a person. And she went on to account of all the things he used to do that he just disappeared from. And I'm going to ask all of you to do the same inventory and think about feeling free, feeling in control. Think about really the things that are wide open to you. Psoriasis should never, ever again be an obstacle to moving forward and exploring anything at all you want in your life. And if your response to that is, I'm not the kind of person, I tried that before, I could never, it could never. If any of you have children, you had a long list of I could never and it could never. So every day is a new chapter. Every week is a new chapter. I want to shut up and have Dr. Cutler speak. He's a wonderful, wonderful person. And again, just thank you all so much for being here and giving the opportunity to bidirectionally learn.
Okay.
So Dr. Cutler, I'm going to stop sharing. Do you want me to go back to your beginning of the slides and start there again?
Yeah, that would be great. Thank you.
Okay, sure. Just a moment. I'm going to stop so you're not going seasick. All right. Can you see the screen now?
Yes, there we go. All right. Well, thank you so much, Dr. Fried, for a wonderful start to this topic. So I will carry the baton here. So I wanted to talk a little bit about stress, and particularly stress and chronic illness. So as we all know, there are two kinds of stress, right? So there's good stress, beneficial stress, which helps us adapt to situations of change. And then there is the pathological kind of stress that makes adaptation impossible. I think, as many of us have experienced, there is a bidirectional relationship between stress and the worsening of a chronic illness. This has definitely been demonstrated in psoriasis and also in a lot of other illnesses that we treat, particularly cardiac illnesses, where there's been a lot of study and research. And essentially what a bidirectional relationship is that when you feel overwhelming pathological stress, your health becomes worse, and that makes stress much worse subsequently. The relationship actually between stress and psoriasis is well known, and it was actually first discussed in print and published in 1954 by a doctor named Dr. John Ingram. This was published actually in the BMJ, which is the British Medical Journal, in an article titled "The Significance and Management of Psoriasis." So what Dr. Ingram had to say in 1954 was this, which is one other important psychological aspect is the sense of shame, which the patient and the public may entertain about psoriasis. It's important to dispel this and to let it be known that psoriasis is a common affliction of which the patient should be no more ashamed than of acne or of baldness. So this was 1954 when this was first put into print, and here we are today in 2022, still discussing what is a very relevant topic to living with psoriasis. So I think, as Dr. Fried mentioned, the relationship between stress and psoriasis involves a very complex interplay of the nervous system, hormones, and the immune system, specifically cells within the skin, likely leading to a pro-inflammatory environment, not only within the skin itself, but also affecting other organ systems. A lot of this has to do with a particular neuroendocrine component of our brains and bodies called the HPA axis, which kind of connects our brains to our bodies with regards to stress. And chronic stress, of course, will lead to kind of a breakdown or a malfunctioning of this particular axis, which leads to very high levels of stress hormones in the body. And this, of course, also affects the skin. So multiple studies have found an association between a stressful event and a psoriasis flare, and stress may also interfere with the efficacy of proven treatments. We also know that stress can slow wound healing as well, and that stress has an effect on the epidermal barrier, which can maintain inflammatory skin reactions. We can move to the next slide. So talking further about stress and the stress of visible illness. So degradation of quality of life and feelings of stigmatization can also lead to worsening stress and, of course, trigger depressive episodes and anxiety. Interestingly, looking over a lot of the research that has been done on this topic, it's not only personal stress that can affect the state or condition of psoriasis or of a current flare, but also stressful family events that have been shown to also affect flares. Stress also has an effect on children with psoriasis. In one interesting study, an episode of stress before a flare was reported in about 90% of children who had been diagnosed with psoriasis. And then, of course, there are concerns too about the additional ramifications that childhood flares can have on the life course. So coping and coping mechanisms, we've talked about quite a few of them. They are predictive of the mental health of patients with psoriasis. And one of the most utilized coping strategies by patients with psoriasis is adaptation, like hiding visible plaques or avoiding activities. And I think we saw a little bit of that in the poll that was taken earlier. And of course, both medications and non-pharmacological treatments can be helpful for patients with psoriasis and comorbid depression or anxiety. We can move to the next slide. So I think talking a little bit about hereditary links and the stress maybe of having psoriasis and knowing that you might be passing that on to a child. So having a family member with psoriasis does increase the risk for developing. There is about a 10% risk if one parent has psoriasis and a 50% risk if both parents have psoriasis. And of course, as I'm sure everyone here already knows, there is no one single gene that is responsible. The age of onset can be either around age 20 or later in life. And then, of course, the best defenses are going to be education and a good dermatologist, so that you know what to do or know what to screen for should you see that a child is developing a flare. So we can move to the next slide. So specifically on the topic of anxiety and psoriasis, so as we talked about earlier, symptoms of anxiety include feeling restless or on edge, or an inability to concentrate because of ruminative thoughts. Shortness of breath, heart palpitations, sweating, and feeling tense are also symptoms of anxiety. So rates of depression in psoriasis are higher than rates of anxiety. However, people with psoriasis do tend to develop anxiety disorders at rates higher than the general population. And depression and anxiety kind of tend to be best buds. So it's unusual to see one without the other. In people with psoriasis, there is some thought that systemic inflammation may be a contributing factor. And there have been studies that have demonstrated that actually treatment with a biologic agent significantly decreases anxiety in patients with psoriasis, which means that there is a deeper association between the two. And I think that is it on my end.
It is. Would you like me to go to the last slide that Dr. Freed had?
Sure, we can go to that last slide.
Okay, I'll stop sharing so you're not getting dizzy. There you go.
So Vanessa and I believe, are in harmony on this. And yeah, many of you are aware there is a new suicide hotline known as the 988 suicide hotline. And certainly if pervasive thoughts that are causing anxiety, that they might not be able to be controlled, and intent for self-harm, in those situations when people have active thoughts of suicide and are fearful, they should either seek ER or the 988 suicide hotline. Help outreach if anxiety and depression is clearly present. If any of us are dealing with persistent, intrusive, and very hurtful anxiety and depression, we certainly should reach out. Help outreach if difficulty performing life's necessary activities. And as I said before, sometimes people can get through their life necessary activities, but really it is a struggle. Help outreach if diminished interests in pleasurable activities, family, friends, flowers, sports, food, sex, etc. And as I alluded to earlier, that idea that so many people confuse mild depression with aging, and they accept it as what they think life owes them at this point in their life. I think all of us know 90-year-olds who are spunkier and more excited about life than 20-year-olds. So think that it's possible it could be this psoriasis. Help outreach of desire for objective ear for problem solving. You know, talking to friends and family is wonderful, but sometimes just reaching out to someone that doesn't have history with you, doesn't have their own agendas, doesn't want to potentially tell you things you wouldn't want to hear or need to hear, where a health professional can. And why not growth and self-assessment? Many people on this call know a dermatologist by the name of Francisco Tausk. He goes by the name Pancho. He's very interested in psychodermatology and the role of stress in skin diseases. And he said when he came to America 18 years ago, he's from South America, he found it very odd that Americans, if we want to become better golfers, better tennis players, better bridge players, better pickleball players, we take lessons. But when it comes to navigating emotions in life, somehow we don't do that. He said in his home country, people were regularly in and out of therapy just to problem solve and just to move forward in a healthy direction. Now, seek help can be a professional person, psychiatrist, psychologist, licensed clinical social worker. You do want someone with credentials, but there are a lot of online available help opportunities as well. Again, I just caution that you know who the source is. And Vanessa, you may want to speak to this a little bit more.
Yeah, I think, this is a really important topic, kind of along the same vein of only seeking out information from reputable sources. Really, you should only be seeking out medical care, psychiatric care from reputable practitioners as well. There are a lot of services, particularly online, and that have kind of mushroomed since the beginning of the pandemic, that promise wraparound psychiatric or psychological care, and really have not been able to deliver on those promises. So I think that Dr. Freed raises a very good point here, that it is extremely important to seek out help if there is concern for worsening depression or worsening anxiety that is debilitating, but to seek out help, again, from reputable sources. And one of the places to start, of course, would be looking at sources online like NAMI, which is the National Alliance for Mental Illness, which is a very good reputable source, as well as local academic centers or hospitals, who may also be able to share resources too.
Okay. If I can just segue to one other concept, I want to talk about placebo, nocebo, and natural. And many of us know that the placebo is a positive expectation affecting outcome. So if someone gives me a vitamin B12 pill and tells me, absolutely, I will have a 30% increase in energy and enthusiasm by 8 a.m. tomorrow, a fair number of people will in fact get that because of expectation, positive expectation. If you look at the package insert for every medication that's FDA approved, they must, by law, give you the effectiveness of the placebo or the sugar pill measured against the active medication. If you look at the package insert for the little blue pill called Viagra, which, as you know, is given for erectile dysfunction, approximately 30% of people get the exact same response with the placebo. There's a psychiatrist at Harvard, the last name is Spiegel. He has a wonderful, wonderful saying. It's not just mind over matter, it's that mind really matters. Now, recently, they've been talking about the nocebo effect. And the nocebo effect is a negative expectation. And they actually did a study recently where they put sensors on people's head, measuring the different areas of the brain that were active. And the experiment was the follows. The first group were given a little needle into the skin. And the first group was told, you'll hardly feel this. It's very quick, it's very simple, it's virtually painless. The pain centers in the brain remained inactive. The second group got the exact same needle. Not only did the pain centers light up, but even before the needle touched their skin. So it really is proof that expectation, positive and in this case negative, does affect physiologic changes for better or for worse. Now, I said placebo, nocebo, and natural. Let's talk about natural. I saw an emergency room doctor yesterday morning as a patient. They had a patient admitted overnight because they went into liver failure using kava, a natural nutraceutical, thank you. And they had an allergic reaction to kava, and kava is known to be liver toxic in many patients. So just because something is labeled as natural does not suggest in any way with certainty that it is more or less likely to be harmful. Poison ivy is natural. Many cardiac medications that you can easily overdose in, digoxin being one of them, is natural. And it's an interesting thing, and I'm going to digress to COVID again for a minute. When people said, I don't want to take that vaccine because it's not natural and it hasn't been tested. There's a Johns Hopkins immunologist who framed that very nicely. And she said, our immune system is getting vaccinated approximately 50 to 100 times a day. The food we drink, the air we breathe, the water we drink, all have virus, bacteria, fungi. So we are constantly taking impurities into the body. Our immune systems rise to the occasion, take care of them, usually don't overreact. The difference between the random things that enter our body during the day and a tested prescription is the tested prescription, the ingredients by law have to be tested for sterility and purity. And many of the prescriptions are natural vitamin based. Calcipotriene, which is in many topical agents for psoriasis, is the vitamin D analog, and it is tested so you know that it is sterile. The quantity is what you want. So when we are putting medicines on our skin, whether it's medicine on a plaque of psoriasis, whether it's medicine on our faces to try to get rid of our wrinkles, whether it's medicine to try to get rid of itch somewhere in our body, our expectation is important. There is no doubt that human touch can be soothing and can be stress reducing. And I'm not diminishing the fact that applying medicines, particularly goopy ones, is not very unpleasant. But we don't have that many particularly goopy medicines anymore. There's a saying in dermatology that says vehicle is everything. And vehicle means, well, there's the active vitamin D or the active vitamin A or the active any of the other things we use, but it's got to float in something. So the elegance of vehicles have gotten better and better. So what I'm really saying is it may be helpful while we put our creams on our elbows or on our thighs or whatever part of our body to take that good deep breath and actually just enjoy, if you can and if you will, the feeling of being touched. Last thing I'll say, and then I'll shut up, is that just like anxiety and depression can be subclinical, meaning we're not aware of it, sometimes alterations in skin sensation are subclinical. There's a talk I give at the Academy called, "Why Does My Skin Feel So Funny?" Now, if we have itch, if we have pain, if we have burning, if we have biting, we have crawling, we know that. But sometimes what we don't realize is the skin doesn't feel quite right. And it's not until you get on a legitimate, effective psoriasis treatment that you realize your skin didn't feel quite right. And it feels so much better with a heating pad. It feels so much better in the shower. And we hear this all the time. And the analogy is when people have cataract surgery done, they often say, "I did not realize how much color, vibrancy, and clarity I lost because it happened so gradually." So whatever you're using, and if it's helping your skin, pay attention to sensation. You may be very surprised that simply one of our new creams, one of our old creams, one of the over-the-counter creams can very significantly improve sensation. What else we got? You want to do Q&A?
Yeah, it looks like we already have a question here from Stephen. A question for both doctors. What do you think of medical marijuana as a treatment, both for the stress that can come from psoriatic disease and other chronic diseases, and for the physical pain that can come from these diseases? So I can go ahead and start. I was actually just having this conversation with some friends of mine who are psychiatrists, and I'm a child psychiatrist as well. So I meet a lot of adolescents, and I'm asked this question quite a lot actually about medical marijuana. And I will say that currently there is no literature to support use for any psychiatric indication. The American Psychiatric Association has commented on this, and we have frankly no literature to make a recommendation to utilize any kind of medical marijuana product for use of treating a psychiatric illness. In fact, what we see in clinical practice, and what also the medical literature has shown, is that chronic marijuana use actually is associated with a psychotic break or psychotic illness, and also tends to make an underlying anxiety disorder worse. We think that that also has to do somewhat with withdrawal from marijuana as well. So unfortunately, I'm frequently the bearer of bad news when I answer this question for people, but there just frankly is no literature to support a recommendation. The follow-up question obviously is THC or is CBT, not CBT, is that what it is? The supplement that is also produced from the cannabis plant, which some people will use for pain. And also there really is not any great data for use, and because it's not a regulated medication, it's a supplement. That means it's not regulated by the FDA, and you don't really actually know what you're getting. So that is kind of my lecture on marijuana use.
I cannot agree any more fully with Vanessa. I feel like we're living in the wild west right now, and we're throwing cannabinoids at everyone and seeing where it sticks. 7 years ago, my mom in Florida, with 4 senior citizen girlfriends, read in Reader's Digest that if you take 11 raisins, soak them in a shot glass full of either gin or vodka, and eat one at a time throughout the day, it will miraculously improve your osteoarthritis. At the end of a month, they had a powwow to discuss the outcome. The conclusion was their pain wasn't any better, but they didn't seem to give a hoot because they were inebriated. And one of the things that happens with cannabinoid use in a subset of people, if not many, is an apathy. And it's been talked about for decades. And whether it's a direct effect of the cannabinoids, indirect, we don't know. But this type of apathy that can be associated with withdrawal from necessary activities, with disassociation from friends, work, what have you, it's very worrisome. And as a pediatric psychiatrist, Dr. Cutler can speak much better than I can about some of the studies looking at the adolescent brain and how chronic marijuana use can really be harmful. So I share the reservations as well. Next question.
Okay, so Dr. Fried and Dr. Cutler, another question is from Amber. Because onset of disease is known to be about 20 years or 50 years, how does the person know if they have had an early onset but been in remission versus late onset only?
So you're talking about likelihood of further disease and prognosis?
Probably.
Yes, she said yes.
So the question with any given person, the day they experience onset of psoriasis, is that because it was hardwired genetically from the moment of conception? Or does it mean there was a genetic predisposition and a so-called second hit? a cold, a flu, car accident, surgery, just some second hit that unmasked it. So that's question number one, that we think it's probably either or both. Number two, why does any given inflammatory condition go into a quiescent or remittive state? And that's true for rheumatoid arthritis. That is true for many other inflammatory bowel conditions. And the question is because sometimes it does. And if you talk to immunologists about ANAs, which is the gross screening test for autoimmune and rheumatoid factor, they say if you took it every week in the course of a year, the levels of auto-inflammatory chemicals vary. So often early onset psoriasis can be associated with more lifelong on and off disease. But sometimes, like people grow out of acne, sometimes kids will grow out of psoriasis and it will just go away. There are some things that bespeak of a little bit more stubborn psoriasis, sometimes scalp, sometimes distal extremities, but the truth is we're all individual. But I think the most important answer to your question is what I call the 4:30 a.m. what if. When 4:30 in the morning, we say, what if my psoriasis comes back next week, next month, 5 years from now? If we can answer a what if with a well then, it's tremendously reducing in its anticipatory anxiety. What if it comes back? Well then, we've got so many amazing treatments on October 22nd, 2022. Look for 3 months from now and 6 months from now. So I answered your question in a very circumferential, inexact way because we really don't know. But what we do know is the most important thing, and that's we can control it or get rid of it.
Thank you, Dr. Freed. All right, we've got another question here from Dr. Lichten. How often do you include medications in the class of antidepressants or anti-anxiety for patients you treat for psoriasis?
So, Vanessa, I'll start with this and you want to finish it? Dermatologists, physician assistants, and nurse practitioners, we're funny people. We are one of two specialties who very infrequently write for anti-anxiety, antidepressant medicines. We have, for some reason, anointed doxepin. Somehow that doesn't fall under our anxiety base there. Doxepin is an older tricyclic antidepressant, and we use that for itch. We use it sometimes for pain. We use it sometimes for sleep and sometimes for psoriasis. As recently as 3 months ago in the Journal of the American Academy of Dermatology, they were talking about medications effective for itch. And there is no question serotonin selective reuptake inhibitors, the so-called SSRIs, and the serotonin and norepinephrine reuptake inhibitors, the SNRIs, can be very effective for itch, as can the older antidepressants. So I think there clearly is a role and should be a role for the selective use of antidepressant, anti-anxiety medicine. And for 25 years, I have been pleading, cajoling dermatologists to judiciously incorporate it because it can make a huge difference in how people do short-term in terms of symptoms, as well as feeling less anxious and being more likely to use their medications. Last thing before we turn it to the real expert in this topic, and Dr. Cutler, is every now and then medicines do funny things. And 10 years ago, I gave 50 milligrams of sertraline or Zoloft to this lovely 26-year-old patient, and I precipitated a full-blown manic episode. I did ask her, is there any history of manic depressive illness in the family? Any history of very, very frequent or wide mood variations? Nope. Every now and then stuff happens. So that, as is true with any medicine or any natural. Dr. Cutler, please correct or clarify.
Sure. So, I see a lot of patients and treat a lot of patients, again, as a child psychiatrist and an adult psychiatrist who have a broad range of skin conditions. And very frequently, in psychiatry, we approach things from a dual diagnosis perspective. And what the literature often says is that treating both conditions concurrently is really going to produce the best outcome. And this is very much a tenet of addiction medicine, which is where a lot of this data has come from. So I think approaching psoriasis and depression both head on is critically important for optimizing or maximizing the outcomes. We have a lot of medications that are effective in psychiatry for both depression and anxiety. And there is a lot of very interesting stuff that's percolating right now with regards to treating depression. So I think for patients who also demonstrate that they do have a debilitating depression or anxiety, it's very important to utilize medications and treatments that are indicated for such too.
And going through my mind as Dr. Cutler just said, that is, there's so frequently an obvious elephant in the room, and to not address it on our part almost seems wrong. It's too strong a word, because I think many dermatologists feel they don't have the appropriate tools. But Dr. Cutler sure is correct that addressing both dramatically improves likelihood of positive outcomes.
Definitely. Another question for you, and Dr. Fried, earlier you mentioned fake book. As the use of social media has increased, how do you see social media impacting the issues we've talked about today? Do you have any tips for your patients with regard to use of social media?
It's a really good question. I think social media has many positives. In many ways, I think it's like a little pocket knife that you can open a package with it, carve something beautiful with it. With that little pocket knife, you can kill somebody. And the power of social media to propagate accurate information, to make available some of the, quote, dirty little secrets we talked about today about how badly people feel about their psoriasis, how out of control and helpless they feel, and legitimizing those feelings and making known wonderful organizations like NPF. I think it can be so very helpful. And what I personally am seeing is more media powerful people, be they newscasters, be they actors, be they athletes, are becoming much more self-disclosive about anything from their borderline personality disorder to their eating disorders to their skin disease. I hope some of those disclosures will not turn us into Will Smith and when vitiligo was talked about. I'm sorry, alopecia areata. That was a bad attempt at humor. I'm sorry. But I really do believe that social media has the power. The question is, how do we help people to sort through what is exaggerated, unproven, potentially dangerous, or frankly wrong? And again, knowledge is power. And I think outreaches such as what we're doing today, outreaches that are made by public figures and public authorities, if you will, I think will be very, very helpful. But just, I guess, Facebook and Instagram should come with this warning that, results may vary.
Yeah, I tend to agree, with Dr. Fried that there are benefits to using social media. And I think some of those benefits are finding communities that are positive communities to discuss psoriasis and issues related to psoriasis. I do think, though, that social media is a double-edged sword. And I think again, as the medical literature is very clear, a lot of people, after looking at social media, actually feel very badly about themselves when they put it away. And this has been demonstrated in a couple of studies now. So I think finding the positive aspects of social media are critically important. I think also ensuring that your information about your medical care comes from reputable sources is also very important. And then being able to put the social media away if it starts eating into a lot of your day or a lot of your time is something to also keep in mind.
That's a wonderful point. And being a bit of a Pollyanna myself, I do think there is a level of Google fatigue, and that people are exhausted trying to assimilate and organize this much information, and from feeling badly about themselves to just feeling overwhelmed. Science has become to be the thing to be distrusted, whereas a social media spokesperson or website is the place to go. And I think people are just really beginning to believe that that might not be true. And coming out the other side of COVID, it just is exhausting. And my belief is the pendulum is going to swing back toward, you know what, let me limit my scope to more legitimate sources. Now, that might be hard for them to know who and what is legitimate. But as someone said to me in the office yesterday, I was talking about her psoriasis and just talking about what the options were. And I'm always very careful to touch a psoriatic plaque. I just feel it's such an important message. As an 8-year-old little girl said many, many years ago, she drew a picture, and from the psoriasis on her knee, she called it happy skin. And that's how she explains it to her other friends and mothers. This is happy skin. It's okay. That as I touched this person's knee, she just looked at me and she said, I can't get this on the internet. What you're saying makes sense. And I think that that's what people are hungry for. Someone to talk to them with compassion, someone to talk to them as a human being or a compassionate organization, which MPF clearly is. Out of the
Great.
mouths of 8-year-olds, babes, that's where we get our kindness from. Yeah.
So true. We've got another question here from Tammy. I've been mostly clear with no new joint pain on Otezla for 3 years. I'm terrified every day that this is the day it comes back.
So there's a bully, there's a boogeyman, and there is a reality. So you're on a medicine that is an anti-inflammatory. Otezla is not an immune suppressant. The medicine does not increase your risk of infection, certainly doesn't increase any risk of cancer. And if you were to stay on Otezla until your 99th birthday, in all likelihood, it would protect you from bad things. By the way, people who were on biologic agents or Otezla and got COVID were less likely to die from COVID. But let's go back to exactly the question. If you come up to a little kid, let's go back to the little kid thing and say boo, they jump, they cry, they startle. You do it again, same thing, do it again, same thing. After a while, it doesn't elicit anything. So if you look at that bully and say, it might, probably won't, if it does, we got you licked because we got 30 other things. So shut up. There's a psychologist who does this with phobias. In the process of making them confront their phobia, whether it's elevator or whether it's being alone at home, she actually calls it her tough guy, tough girl thing, and has the person, if they're alone, say out loud, have the person to say to themselves, if they're alone, is that all you got? Is that all you got? And it sounds silly, it sounds childish, but it's really not, because we can extend your what if. What if I get run over by a car today? What if I drop dead of a heart attack? What if my wife leaves me? It's a what if is endless. And let's go back to what we said before. What if? Well, then talk back to it. If you're responding this way well to Otezla and you ever broke through, every one of the other biologics out there would have it. And if it's one of the things people loved about Otezla is I don't have to take a needle. Well, there's several other oral agents that have become available. So no matter what, you got it. You're in charge.
I love that. Dr. Cutler, do you have anything else to add?
No, I think Dr. Fried, really said it well. And I think that that's a very important point that, well, what ifs can kind of snowball into what if about anything about your day. And I think if that's the avenue that you're taking, then that's a very different scenario. But I think, if the fear or the anxiety is really limited to what if it comes back, I think Dr. Fried is right. There are many other things in the arsenal to attack.
Terrific. All right. So it looks like we don't have any other questions. I think you both gave an amazing session. So if everyone could just respond with any final questions. Oh, sorry.
I did get a question from Nadine. So she had asked me, and I think this is a better question for Dr. Fried, what creams for scalp psoriasis would you recommend? Are there other steroid oils?
So scalp skin is, other than palms and soles, pretty much the thickest skin we have in the body. So what topical steroids do is they get absorbed into the skin and basically push away those overactive immune cells and so-called cytokines, so they stop bothering the skin and creating psoriasis. So we generally use stronger topical steroids in the scalp because the thin ones just can't penetrate deep enough. Steroids come in different formulas. They come in ointments that are like Vaseline. They come in white creams. They come in clear solutions. They come in clear gels, and they come in mousse-like foams. So vehicle matters, and vehicle is personal preference. Also depends. If you have very, very dense, thick hair, creams and ointments are just almost impossible to get to the scalp. So either solution, foam, or even a shampoo is the way to go. If you were follicularly challenged like I am, you have a little bit more opportunity or choices. So to a large extent, it's patient preference. If it's just in the vertex up here in the front, creams are usually, or gels, the easiest, the quickest, they sink in well. Sometimes we'll use a shampoo called clobetasol, which is short contact. Massage it in for 10 minutes before you get in the shower, then rinse it out. The bigger question is, if we're using a class of steroids, class 1 or class 2, is the psoriasis steroid responsive? If it's not steroid responsive alone, sometimes we will add things to it, calcipotrione with the steroids, or sometimes add tar, sometimes salicylic acid. So sometimes we, quote, step it up a notch with combo things. Sometimes that's used in conjunction with an oral medicine. Psoriasis sometimes has an overlap with dandruff or seborrhea. Sometimes we'll use antifungal shampoos like ketoconazole and Nosrel. Sometimes we'll actually use 1 or 2 days of a pill called difluconazole. So in general, people like less greasy things in the scalp because they don't adhere to the hair and make things as unpleasant. Scalp psoriasis can be tough, but there are specific medications that really tend to work quite well, and we can always clear it. There was one other question that came up, and that was, how safe is it to be on biologics long-term? We now have about 25 years of data on the biologics, the first one being Enbrel. Enbrel was the first medicine and first time we could selectively modulate the immune system. That was in 1998. Prior to Enbrel, when you wanted to use an immune suppressant to treat psoriasis or rheumatoid arthritis, all you could do was use medications that suppress the bad pathways, but also suppressed all the good pathways. Things like methotrexate, things like cyclosporin. And these were medicines that did increase the risk of infection. Possibly alone or in combination increase the risk of cancer. Along came Enbrel, only inhibited tumor necrosis factor pathway, and it was a game changer. So again, we have a quarter century of data. We have millions of people. Long-term use does not seem to significantly raise the risk for early death, early demise, or life-threatening infections. Are they reported? Yes. Now, the question is, are they reported in greater frequency than people with psoriasis or rheumatoid arthritis who are not on the medicine? And the answer is, for the most part, not. Are you less likely to get a heart attack or a stroke long-term on a biologic? Yes, you are. Are you less likely, as we said before, less likely to succumb to self-directed autoimmune inflammatory? Yes. So there's no free ride. And I'll never say that if I am taking fish oil for the next 12 years, that I can't bleed to death, because fish oil does make us more likely to bleed. But what this really addresses is, do you ever stop a biologic? And if so, when? And bottom line, that is something to discuss with your dermatologist. If people have been well controlled for a year, 2, 3 years, nothing's been going on. We can entertain a holiday by abruptly stopping. Sometimes we can space intervals between injection or pills and then try stopping. Most of the medicines, we have good luck with recapture, meaning if the psoriasis comes back, do you go back to the exact level of control? And when we only had one, if that didn't give us recapture, we were up a creek. But now we've got 21, 31. So recapture, for the most part, is not something that we struggle with.
Great, thank you, Dr. Freed. And we have more treatments that are coming too in the pipeline.
Innumerable, yes.
Thank you. All right. Well, thank you both for being here today. This has been a very inspiring and enlightening presentation. Certainly something for all of us to think about. So thank you again, and I'll turn it back to Jane.
Actually, I'm going to turn it back to Jason.
Okay.
I'm gonna turn it back. Oh, I guess it's on me. I guess there's nowhere to turn it back to. Anyhow, we are at a point. We're right on time. We're gonna have a 5-minute break. Please enjoy this break. You all deserve it. Stand up, stretch your legs, deep breathing, relaxation techniques, all good things. Beverage, snack. We'll be scrolling through some information about NPF resources during the break. If you have any questions about any resources, anything we talked about today, or anything you hear, type in the chat box. Dana and Audrey, who are behind the scenes, will get back to you with whatever's there. So please enjoy your break, and we'll be back in about 5 minutes. But in the meantime, like I said, there's some information that we'll be scrolling. So volunteers really are at the core of our mission. Contribute your time, your talents. You're helping improve the lives of millions of people who are affected by psoriasis and psoriatic arthritis, and helping us move closer to a cure. You can find Team NPF walk, bike rides, stamp out events in your area. Also do it yourself. There's plenty of ways to get involved. You can join our advocacy team to advocate for policies that improve the lives of people with psoriasis and psoriatic arthritis. You can become a social media volunteer. We can send you posts. You can forward to your pages, become an influencer there, make Facebook more meaningful. We also need citizen scientists, one-to-one mentors. You can head to the volunteer page on the NPF website or contact us at volunteer@psoriasis.org for more information. The one-to-one program connects people with trained volunteer mentors who truly understand the challenges of psoriatic disease. You can sign up today on the NPF website and get matched with someone who can offer support, resources, and the information you need. Knowing you're not alone and having someone who understands your plight really, I think, is one of the greatest things that the NPF here has to offer as well.
And the link of this for the one-to-one program is also included in the chat. And I forgot to mention that after the conference, we'll make a list of all of the links that were put in the chat, so you don't need to worry about missing any of that information.
Our spot is a place for youth. Psoriatic disease presents a unique challenge for kids and families, something we've really valued from the NPF. It has what you and your children need. Webinars about the disease and care, tips on communicating with teachers, friends, and even bullies, and downloadable resources you can take to school. Plus, you'll find stories from young people around the country who are living with and thriving with psoriasis and psoriatic disease, all free at the Our Spot page of the NPF directory. You see the link there on this page here as well. This is something that the Patient Navigation Center is really, I think we all at the NPF are very proud of the way this has grown. Psoriatic disease is complicated. You have to deal with symptoms, flares, treatments, and related disease, finding healthcare providers, and cutting your way through the red tape of healthcare and health insurance. The Patient Navigation Center can help you with all these challenges at no cost. Whether you're diagnosed yesterday or 20 years ago, whether you need help today or for the long haul, patient navigators are ready to help. Navigators can help you find a healthcare provider, learn about treatments and health insurance, locate programs that may lower the cost of treatments, and connect with other people living with psoriatic disease. Navigators are happy to work with families and caregivers as well. Many of you here today are new to the NPF. Welcome. We're very excited to have you here. There's so many ways to continue your connection, learning about psoriatic disease. You can see the links here for Facebook, Twitter, Instagram, and LinkedIn as well. Well, we'll get to the podcast as well. But so follow the NPF, learn more updates and things in your area. You can sign up to be on the NPF email list. This will include advanced weekly digital magazine, emails to request a monthly Patient Navigation Center resource, learning about clinical studies and volunteer news, educational podcasts, and webinars. You can sign up on the NPF website on the bottom of the homepage or by entering the bit link that's here on the screen. Soundbites is the NPF's podcast. Dr. Fried is actually featured on one. You can hear that. All the old podcasts are downloadable as well, wherever you get that through the podcast or Spotify. You can also find Sam Lichten on a podcast. I highly recommend that one. But there's a lot of things. If you're short on time, 30 minutes, hour in the car. This is a great resource to learn new information.
And there's new episodes that come out, usually every other week or so. Not to mention all the previous wonderful episodes that we had. So Jason, that's it for our public service announcements. We've got a minute left on the break, so if you need to take a break, go for it. And
all right.
We'll be back in just a minute or two.
Perfect.
All right, Jason, are you ready to start back up again?
Yeah, I am good here. As I told you, Audrey and Dana, we're going to be busy in the background. If you look at your chat, all those links, there's a lot of links there, information. So go back to your chat and pull those as well. So many of you, our next presenter, Craig Eng, many of you had the pleasure of meeting him at the NPF Community Conference in Chicago last April. His introduction to Qigong was so well received. We've asked him back here for our fall virtual conference. Craig Eng is the owner of Eng Martial Arts and Advanced Training in Schaumburg, Illinois. He is a lifelong martial artist, having studied and holding ranks in multiple martial arts styles. He possesses more than 25 years of teaching experience. With degrees in teaching and kinesiology, Craig is an author, a lecturer, and an accomplished therapist specializing in orthopedics and sports medicine. Further holding multiple credentials and certificates, Craig has trained and coached people of all ages and abilities. This is really, you're in for a treat. So with that, Craig, I will turn it over to you. And thank you for being here.
Thank you. Sorry, there's a little technical difficulty here. All right, so we talk about Qigong. Qigong is a form of traditional Chinese exercise. It ties into traditional Chinese medicine as far as for health promotion. Closely related to Tai Chi. Many of us have heard of that. Some of the movements might be very similar to some things that you've seen in Tai Chi practice. Qigong, quite simply, is about circulating, breathing, body movement, everything tied together. Circulating energy is a hard term or hard concept for many of us to comprehend, but it's about coordinating the breathing and movements. So it's a good, very low to non-impact form of exercise and is good for helping our bodies to move a little bit better without necessarily aggravating some of the injuries or ailments that we might have. Many of us have joint problems or restrictions, arthritic changes, degeneration. The Qigong exercises can be done to help our health and wellness without aggravating these things. So I want to go ahead and start with a few things. If you're more than welcome, please join me. I'm going to kind of move around a little bit so you can kind of see what I'm doing. But as I said before, Qigong is about breathing first and foremost. So I'm going to try a little bit of breathing exercise. What I'd recommend, let me just adjust here, is you can sit or stand, whatever's more comfortable for you. Hands over the belly button, okay, right over the abdomen here. And we're going to take a big deep breath in through your nose and fill the abdomen. So inhale and exhale. Let it out from the mouth, emptying the belly. Nice big deep breath again. And exhale. Do a few more of those. Big deep breath in. And exhale. Again. And exhale. Now, again, the beauty of Qigong exercises, we can do them and modify them any way for our abilities or our limitations. So if standing is a little rough for us, we can always do things sitting down. Same thing, sitting, hands on the abdomen, breathing in through the nose and out through the mouth. Now, all the exercises that we're going to try today can be done sitting or standing based on your needs. Also, remember that you don't have to do the full motion. Every little bit counts, so we do the best we can with what we have. When we try another breathing exercise, this time we're going to hold our arms out in front of us. And so, okay, like you're holding on to a tree. Now, as you take that big deep breath into the belly, raise the arms up just as high as your body will allow. Inhale, and then exhale, let it back down. Now, if you have shoulder problems, as low as you need to. Inhale, exhale. Again, big deep breath in, fill up the abdomen, and let it out. Exhale. Again, big deep breath. Exhale. Nice and slow, nice and relaxed. Nothing is tense in the body. Inhale. Exhale. Inhale. And exhale. Okay. If anybody has any questions or any problems, feel free to throw that up there for me. Next one, we're going to do a little bit for our upper body. Again, don't go too high if it aggravates your shoulder. You can limit the motion, lower the body. Sitting up nice and tall, put one hand out in front of you, and you're going to brush your arm. As you do, you're going to turn and rotate to one side. Inhale, brush the arm, rotate to the other side. Again, if you need to sit down, feel free. Inhale. Exhale. Inhale. Exhale. Again. Exhale. Inhale. Exhale. Okay, now if your shoulders are starting to feel a little tired, slow this down. You can always just roll the shoulders a little bit, let them go, just move around a little bit so they don't get aggravated. And go the other way. Okay. Now, another breathing exercise that we can do. You can hold your hands out in front of you, just below your face, about head width apart. Okay. Try and keep that upright spine the best you can. As you inhale, separate the hands to about shoulder width apart. Exhale, bring them back together. And everything should be nice and relaxed, no tension in the body. Inhale. Exhale. Again. And out. Small movement is fine. Just make sure that you're breathing. Keep everything relaxed. Inhale. Exhale. Inhale. Exhale. We'll do one more. And out. Okay, just relax the arms for a second. Move on to the next one. I'm going to put the hands out in front of us, like we're holding on to a bowl. Now I'm going to draw a large circle with my arms and back down. Again, as large a circle as your body can tolerate. Don't force the motion. It can be a small one. And if you don't have any problems, you can always make a bigger circle. Okay, so inhale on the way up. Exhale on the way down. Again, inhale. Exhale. Nice and slow and relaxed. Inhale. Exhale. Inhale. Exhale. One more. And exhale. And relax. Hope everyone's feeling okay so far. Next one. I'm going to hold the ball. So one hand on the top, one hand on the bottom. We're going to, as we inhale, filling up that belly, don't forget, separate the hands. One hand goes up, one hand comes down. So from here, as we inhale, bring it up. Exhale, compress. Kind of like you're squeezing a spring. Inhale. Exhale. Inhale. Exhale. Inhale. Exhale. One more. And now roll the ball, and let's do the other side now. So inhale, fill the belly, separate the hands. Exhale, close it down. Again, inhale. Exhale. Inhale. Exhale. A couple more, nice and slow, nice and relaxed. And relax the shoulder. Very nice. Next easy one. From our hands out in front of us, we're going to take a nice big deep breath in and separate the arms. Inhale, fill it up. Exhale, close it down and kind of round forward a tiny bit. And don't strain too much and don't curve too much forward. Just a small motion if you need to. Open and close. Again, open and close. Now remember, if we have shoulder issues or spine issues, we can always lower the hands and work them down here. Inhale, exhale. Work with any limitation you have, you can still get the benefit of the exercise. Inhale, exhale. Again. Inhale, exhale. Inhale, exhale. A little harder one, a little more challenging. Kind of brush the arm again. My elbow is going to go up toward the ceiling, again, with the limitations that you might have. Inhale as the elbow comes up. When it gets up to about your face high, change the hand, push up toward the ceiling. The other hand pushes down to the side. Exhale. Bring it back. Inhale. Push 2 directions. Exhale. Inhale. Exhale. Getting more air in, improving our circulation. Inhale. Exhale. Inhale. Exhale. Again. Inhale. Exhale. One more each side. Inhale. Exhale. Inhale. Exhale. Good. Next one. Going to help our neck a little bit, help our circulation and our movement through our neck. Sitting up straight, we're going to put the hands out in front. Inside, you can see like so. I'm just going to turn my head to one side, turn my head to the other. Just breathe natural and normal. Rotate to one side, rotate to the other. To the left, and to the right. Left, and right. Now, second posture, same rotation, arms down by your side. Turn left, and turn right. Breathing naturally, nice and easy. Everything is relaxed. To the left, to the right. One more each side, left and right. Last one, same posture, hands behind the back if you can reach there. If you can't, just pull them back. You can get your hands on your back, great. And then same, you're gonna rotate to the one side and then to the other. Keeping those arms back if you're able, rotate to one side, turn to the other. Back left, and right. Make sure you're breathing. Left, right. One more, left, and right. Okay, relax the arms, kind of shake out the hands a little bit. An easy way to let everything relax is 4 hands knocking, just letting arms and legs just kind of swing down side to side. Nice and relaxed, just breathe normal. Okay, 4 hands knocking. Next one, Shaolin breathing. Bringing your hands up, palms up, bring them up to the chest or as high as you can comfortably. Push forward. And down. Okay. Bring hands up toward the chest. Exhale, push forward and let them down. Again, inhale, bring them up. Push forward. And down. Few more. Big deep breath. And out. Down. Up. Forward. Down. Forward. And one more. Hope everyone's feeling okay so far. Sorry. Again, this time we're going to put the palms up and we're going to push one hand forward and the other hand back toward us. And let them out. Okay. So a little bit higher. Bring the hands up. Push one hand forward, the other one back. And down. From the side. Bring it up. One hand forward, one hand back. One more time and we'll switch. Up. One hand forward, one hand back. Now the other side. Up, inhale. One hand forward, one hand back. And up. And press. Keep breathing, keep the spine upright, but relax. Up. Forward. Up. Forward. Okay. Now, next one. Qigong ties to Tai Chi, which is a martial art. So this one looks very martial art like. We put our hands on our hips. I'm going to bring one hand out and forward in a punch. Rotating my trunk forward slightly. You're not locking it out there, you're not jamming out that punch. Just bring it up and forward. You're going to turn your body slightly. Bring it back. Loose hands, up and forward. And back. Up, forward. And back. Make sure you're breathing. Inhale, exhale. Bring it back. Inhale, exhale with the punch. Rotate that trunk into that punch. Bring it back. Up, forward. Up, forward. Then. And again. Relax those shoulders, make sure you're breathing. If you're getting a little tired, feel free to take a break. Do the best you can with what you got. Okay, let's shake out the hands a little bit. And me. Okay. All right, now let's try linking some of those together into a set, a full set. We can do, when we practice Qigong, you can practice one or two movements. You can practice just the breathing, or you can do a full set of movements or pattern. Whatever works for you, it's just a nice way to get everything going. And again, we're coordinating breathing, mind, and body together. So we're going to do the 5 elements Qigong set. So you can sit or stand, again, whatever's more comfortable. Separate your feet out about a little more than shoulder width apart. Tall spine, bend the knees slightly if you can. Again, if you need to sit, that's perfectly fine. You're going to put the hands over the belly again. We're going to do that breathing first. So big deep breath in, fill up the abdomen. And exhale. Again, big deep breath. Exhale. One more time. And exhale. Now we're going to go bring the hands up to this one here where the hands are below your face. Inhale, separate. Exhale, close it together. Inhale, open. Exhale, close. Again. Again. And do one more. Put those arms down for a second and put the hands back at the abdomen. And again, we'll do 3 breaths. Big deep breath in and exhale. Inhale. Exhale. One more time. And exhale. Put the arms down and relax for a second. Now the next one is just like the breathing exercise we did, but we're just going to squat our body down a little bit. Those of us with knee problems, go easy, but hands on the abdomen. As we inhale, we're going to sink down into our feet just a tiny bit and exhale. If you're sitting and you breathe, you can just kind of crunch down a little bit. So inhale, sink in, exhale, rise up. Again, inhale, sink in, exhale, rise up. Again. 2 more. And 1 more. And relax the arms. And go back to the hands at the abdomen, this time just the breathing for 3 reps. Inhale. Exhale. Inhale. Exhale. Inhale. Exhale. And relax the arms. Let's bring the arms back up, out in front of us, holding that bowl. And draw that circle the best you can. Inhale, make that circle. Exhale, bring it back down. Again, if you need to limit that motion, that's perfectly fine. Inhale. Exhale. Inhale. Exhale. One. Do two more. So you're breathing. Inhale. And exhale. Let your arms relax. Back to the abdomen. 3 breaths. Inhale. Exhale. Again. Exhale. One more. Exhale. And let the arms down. Last of the postures, back here, ball position. As we inhale, we separate the hands. Deep breath in, empty it out, compress. Again, deep breath. Exhale. Inhale. Exhale. Inhale. Exhale. Now roll that ball. Let's do the other side. Inhale. Exhale. Inhale. Exhale. Couple more. Inhale. Exhale. One more. Inhale. And exhale. Put the arms down and relax. Go back to the abdomen one last time. Big deep breath in, fill it up. And exhale. Again, deep breath in. Exhale. One more time. And exhale. And relax the arms. All right, shake out the hands. Excellent work. Hope everyone felt good with that. Now again, Qigong, there are hundreds of different variations, different systems of Qigong. Qigong exercises, again, are meant to circulate energy and coordinate breathing, body, and movement. Tons of resources out there at your local library, on the internet. There's tons of things. There's very low to non-impact exercises, so anyone can practice them, anyone can enjoy them. Different ways to practice them are, like I said, just breathing. Just doing that deep abdominal breathing, moving around. Those little calisthenic type exercises do a lot for us physically and mentally. Tons of resources. And what did Audrey put? There are board certified Tai Chi instructors. Tai Chi for Health Institute is a good one. I actually hold several of their credentials. They have videos that everyone can watch or follow along with. Great instruction on those. There are other resources out there, so I certainly encourage you, if you're interested, to try and just sample it and see if there's something that you can work for yourself. Let me do a couple more breathing exercises and then I'll get out of your way. So nice and easy, arms down by your side, big deep breath, like you're bringing a bucket overhead, and then push it down to the side. Deep breath, bring it up, and down. Again, deep breath, and down. Couple more, big deep breath. Put it down. One more time, bring it up, and push it down. Okay, now last one, if you're able, bend forward at the hips, let your arms hang down toward the floor. Big deep breath in, raise those arms up as high as your body will allow. Reach toward the ceiling if you can. Exhale, bring it forward. Open up. And exhale, let it out. Again, big deep breath. And okay. All right, hope everyone enjoyed. If there are any questions, feel free. Well, hope everyone enjoyed. Thank you. Right hand closed, left hand over, and salute.
Thank you, Craig. That was so relaxing.
Glad to hear it.
Thank you. If
Thank you.
anyone has any questions, please, you can use the chat there. I will admit that, you know, standing in the parking lot here, people may have looked at me funny, but that's all good. It's okay. So that was the only part that wasn't quite as relaxing, but that's only because of my situation where I'm sitting. But excellent. Thank you also. Thank you so much. And you see Dana has put in the chat a link to find more gentle movement exercises there in the chat. All right, so I think we're going to move on to the next portion of our program, where I get the privilege of introducing Jess Smith. We have Jess on here somewhere, hopefully.
Hi, yes,
Good.
I'm here. Thank you so much for introducing me. Good morning, everybody.
Absolutely. So let me tell you a little bit about Jess, and then she's going to give you a presentation on the research highlights. Jess is the research programs manager here at the National Psoriasis Foundation. She's working remotely from Atlanta, Georgia, where she oversees the funded research, which is grants and fellowships portfolio. Jess is also responsible for the research events, the NPF Victor Henschel Biobank samples, and participates as a content editor for JPBA, contributing content for the CME podcast and medical board niche paper support. She also serves as staff liaison / oversight of the NPF research committee, which I'm happy to serve on with her. A board delegated committee, which is intended to make sure the NPF's funded research is aligned with the mission and vision of the NPF. Just graduated from the University of Florida with a degree in behavior and cognitive neuroscience and a minor in innovation. She brings experience from University of Florida Health, Jacksonville, and the University of Florida College of Medicine and Emory University. In her free time, Jess can be found spending her time with her two pets, a golden retriever named Gracie Bell and a cat named Nix. Is that right, Nix?
That's correct. Nick's like the goddess of night.
She also cooks, and as you can see here, most often she enjoys hiking. So with that, I will turn it over to Jess to tell you about some of the research initiatives.
Good morning, everyone, and thank you for that lovely introduction. I apologize, I'm not joining on camera today. We are actually attending Fall Clinical here in Las Vegas. So I am at our exhibiting booth here, which is going very, very lovely, but I'm excited to spend a few moments of my time today talking to you guys about our funded research portfolio and also Go Gators, yes. So thank you everybody for introducing me. So as it says on the screen, I am here to discuss the NPF research programs with a focus on our More Than Skin Deep mental health initiative. Given the proprietary nature of research, there's only so much I can share about our active portfolio. A little bit of information about the research process is results from research. We are moving towards an open access policy. So coming up or down the pipeline, we will be having open access requirements after a certain amount of years. And the research is published from NPF funding. So that's something really exciting where we will be able to start sharing and disseminating more information that comes from our research. The outcomes take time because science takes time. So right now, some of these mechanisms are newer and we're really excited to see where they go. We can advance to the next slide. So why fund psoriatic disease research? And this is actually kind of a question for you guys. So if you want to pop it into the chat or if you want to, I'm not sure if we're able to unmute yourselves, but if you want to unmute yourselves and kind of call out a few things, why is psoriatic disease research funding important for the psoriatic disease patient community? I can't see the chat, so I'm not sure if there's anything in there. Oh, go ahead.
I unmuted myself. This is Stephen Keat. It seems to me like that's a question you don't need to ask. It's probably the single most important thing that the NPF can be involved with. It's to help not only deal with our day-to-day problems with psoriasis and psoriatic arthritis, but to hopefully eliminate them and eliminate the disease in the future.
Exactly. You have hit the nail on the head. Our goal as the National Psoriasis Foundation was, of course, to reduce the burden of chronic disease and psoriatic disease specifically. We want to alleviate these burdens. We want to find a cure. We want to find preventative measures and better access to care. So we're funding psoriatic disease research in order to increase or just to reduce the burden of psoriatic disease on the population and for future generations. Next slide, please. Thank you. So as you can see on the screen, we have the NPF 2022 research commitment. We are very excited that on July 1st of this year, we did announce that we funded $3.2 million in psoriatic disease research. That's just in one research fiscal calendar. So we do fund every year, and this is announced July 1st of every year. On the screen, I'm not going to discuss these mechanisms in depth because I will a little bit further, but as you can see, this is where we allocated our money to. There was $1.5 million to the Psoriasis Prevention Initiative, $650,000 to the PSA Diagnostic Test Grants, $300,000 to Psoriatic Disease Research Fellowships, $100,000 to the R01 level bridge grant, which we're going to talk about in a little more detail because this is a really, really important mechanism for the scientific community and moving science forward. We did $20,000 to the summer student research grants, which is an excellent training opportunity. We did $150,000 to discovery grants, $100,000 to early career research grants, $300,000 to translational research grants. That is in one first-year award and two second-year awards. But an exciting fact about this is actually a two-year, $200,000 commitment. So this is representative of 1 year of that funding. So this is a $600,000 commitment. And then $100,000 commitment to the More Than Skin Deep mental health grant in this current year. In the prior year, we did fund 3 of those mechanisms, but I will get into that in more detail on an upcoming slide. If we could advance to the next slide, please. So we're very excited to announce that we're increasing this commitment to research funding even further. For 2023, our announced research commitment is $3.67 million in research funding. So very exciting number. Our leadership team is committed to making sure that we are moving strides in the right direction for the patient community and to continue increasing that commitment each fiscal year to make sure we are funding more research and we are making those strides. We can go to the next slide, please. So we do have a few mechanisms. So first we'll discuss briefly the traditional grant mechanisms. Traditional grants are offerings that host each year. They don't necessarily have a niche focus, but they are something that, oh, could we go back please? One slide?
I don't know what happened.
No, that's okay. So this is something that happens every year. We host these offerings. So discovery grants support preliminary and proof of concept data studies. They're 1-year awards of up to $75,000. We have the early career research grants. This is a training opportunity that supports graduate students and postdoctoral researchers focused on psoriatic disease and related comorbidities. These are primarily intended to bring new researchers into the psoriatic disease research space. They are 1-year awards up to $50,000, but they are, again, intended to bring more people into this research space. We have the More Than Skin Deep mental health grants, which support basic and clinical science addressing mental health as a psoriatic disease comorbidity. These focus on both the basic science parts, so the underlying genetic causes, the inflammatory impact of mental health, but it also focuses on, self-perception, anxiety, depression caused by disease burden, cost of resource, access of care. So this is a really broad mechanism focusing on that mental health comorbidity. We have our translational research grants, which support discoveries from clinical, laboratory, or population-based studies, moving treatment to intervention. These are 2-year awards up to $200,000. So the goal of this mechanism is really to take the science from the lab. So where we're examining the genetics, we're looking at factors, we're looking at sequencing, and then turning it into something that is tangible for the patient population. So translating it into the clinician population. It's a treatment and intervention, and sometimes drugs. Clinical trials are often associated in drug development. So it's a very broad mechanism, but it's a very important mechanism. And then we have our bridge grants, which support researchers with competitive but unfunded NIH applications to strengthen resubmission. So what this means is that a researcher receives back a summary statement with a score on their research from the NIH. They were not funded, but they're given critiques in the summary statement. The NPF provides critical gap funding for this initiative related to psoriatic disease. And this gap funding allows them to gather additional preliminary data to support the resubmission and hopefully secure those NIH funds. We offer this at 2 levels, a K type, which is the career development type, and then an R type, which is kind of the golden standard of research, is to poise yourself to receive an R01 level grant at the NIH level. So very exciting stuff. If we could go to the next slide, please. And then we do have training grants, which is something that MPF is very committed to. It's very important to bring new researchers into the psoriatic disease community and to keep them in the psoriatic disease community. So these mechanisms are the psoriatic, could we pop it back, please? Thank you. The Psoriatic Disease Research Fellowship, and then the Summer Student Research Grant. And we can hop to the next slide now. Okay, so now we're going to focus a little more in depth and also look at what we are funding in these spaces. So this is the Summer Student Research Grant. The Summer Student Research Grants support undergraduate and medical students for a summer of research focused on psoriatic disease or related comorbidities. These awards are 12-week awards to be conducted between May 1st and September 1st, and they're up to $5,000. The money in these awards is $4,000 for salary support to these students and $1,000 for lab supplies. It's a really exciting mechanism. It does focus on people who are still in school, but it starts engaging in psoriatic disease at a really, really young point in the career that has the option or the opportunity to be really formative in developing someone's career trajectory. If they get into a lab that's really supportive, if they get into a niche area of psoriatic disease research that they are really passionate about, it fosters it from the beginning. So as I mentioned in FY22, we did fund 4 of these studies at $5,000 each for a total commitment of $20,000. And then on our screen, we do have displayed the awards that were funded. So we have investigating the effects of bile acids on Western diet-induced psoriasis. This is Ellen Chow, an undergraduate student at the University of California, Davis, and she's mentored by Dr. Sam Wong, who is a close collaborator of ours. Then we have augmenting standard of care treatment of plaque psoriasis by neuromodulation. And this is Ayana McLaurin from the Burrell College of Osteopathic Medicine, mentored by Dr. Harold Staus. Next, we have evaluation of the functional effects of the FKBPL mutation and implications for psoriasis. And this is Isabella Stein. She is a doctor at the Royal College of Surgeons in Ireland, and she's mentored by Stephanie Annette, Dr. Stephanie Annette, who is funded in another space. I believe it is the psoriatic or the early career research grant. So we do have a working relationship there as well. And then we have evaluation of skin cancer screening practices for psoriasis patients. And this is Teresa Zhao at the University of Chicago. And this is mentored by Dr. Ruiz. Yeah, we could go to the next slide, please. Our next is another training mechanism. This is the Psoriatic Disease Research Fellowship. This is a really exciting training opportunity because this is at the postdoctoral phase. So these are people who have finished or they've completed their preliminary training for the PhD or the MD route that they're going on. These awards are intended to support MDs or outstanding medical students for a mentored year of research focused on psoriasis, psoriatic arthritis, and comorbidities. It is $50,000 in direct salary support, so it reduces the burden of the institution's cost in supporting these fellowships, and it is required that they are partnered with an established researcher. We did fund, I believe the exact number is 7 of these awards this year. It was either 6 or 7 for I do think it was 7 though, but for a $350,000 total commitment. And the FY22 awards on our screen are the role of intermittent fasting on disease severity and quality of life in psoriasis and psoriatic arthritis. We have Dr. Ashley Gray, mentored by Dr. Kaffenberger, both from the Ohio State University. We have characterization of the psoriasis glycome to identify biomarkers predictive of psoriatic arthritis and cardiovascular disease. So predictive biomarkers on who will potentially be more at risk for psoriatic arthritis and cardiovascular disease, which is a comorbidity of the psoriatic disease population. This is Dr. Ju Zhu from the University of California, Davis, and mentored by Dr. Mavrakis. We have defining immune cell trajectories from blood to psoriatic skin. So just looking at, how the pathology impacts the inflammatory responses in the skin. And this is Dr. Jin, mentored by Dr. Liao at UCSF in California. If we could go to the next slide, please. Oh, so it was 6 awards for $300,000. So the next 3 we have are itch intensity in psoriasis versus atopic dermatitis versus chronic idiopathic urticaria, a meta-analysis. Oh, can we go back, please?
Yes,
Thank you.
I apologize,
And this,
Jess,
nope,
there's
that-
something with the slides that's jumping them automatically.
no, that's okay. So it's Dr. Tan Renahan at Beth Israel and mentored by Dr. Kimball. We then have the impact of shared decision-making on patient satisfaction and medication adherence among psoriasis patients in the US. And this is Dr. Yi at USC, mentored by Dr. Armstrong, who's actually here with us today at Fall Clinical. We've been able to attend some wonderful talks with her, and she's actually recording a live podcast this afternoon. So really, really exciting stuff. And finally, we have cardiovascular risk and pediatric psoriasis. And this is Dr. Carr, mentored by Dr. Amy Poller at Northwestern University. I would like to mention that the Dr. Mark Lebel Psoriatic Disease Research Fellowship was awarded to Zachary Carr at Northwestern. So he was the donor for this through his endowed fellowship funding. And Dr. Lebel is actually here and one of the sponsors or organizers of the Fall Clinical Conference as well. So we're very excited to be spending some time with him while we're here in Vegas as well. And next slide, please. Okay, so here's this bridge grant mechanism. And like I said, this mechanism is really, really unique because it provides that critical gap funding to researchers who are very close to being funded, but just below the funding pay line. A funding pay line at the NIH level means that's where, they have X amount of funds. That's where the scoring line falls, and that's what's funded. So our hope is, of course, for the applicants to obtain additional preliminary data and then go on to receive those competitive awards for the NIH level and the gold standard of awards. So this year we have one or R01 level. So this is the highest level of the NIH funding, and it's the total body PET CT imaging biomarkers for diagnosing and quantifying inflammatory burden of psoriatic arthritis, which is Dr. Ray Chowdhury at UC Davis. This is some really exciting work because the National Psoriasis Foundation is committed to identifying biomarkers for psoriatic arthritis and, of course, reducing the time it takes for diagnosis. Within 6 months, the bone damage can be irreversible. So, of course, as early as possible as we can identify those biomarkers, it would be increasingly helpful to the psoriatic disease community. So this is some really exciting work that kind of feeds off from another grant mechanism that we originally funded, which is the PSA Diagnostic Test Grant, but we'll talk about that more here in a moment. If we could advance to the next slide. Discovery grants. So discovery grants are really exciting because these are preliminary proof of concept data studies. They're 1-year awards of up to $75,000 for supplies and salary costs. These are the idea stages. So they're riskier research studies, but they're asking the questions that have not been asked yet and finding answers. So this is really here's my hypothesis. Is there any merit to this? Is this a route we can continue going in psoriatic disease research? So our FY22 awards, we did award 2 in the amount of $75,000 for a $150,000 total commitment. They were the role of a novel skin regulatory T-cell population in obesity promoted psoriasis with Dr. Lee at Emory University. And then we have using peer mentors to increase the racial and ethnic diversity of psoriatic disease research participants, which is Dr. Takashita at UPenn. If we could go to the next slide, please. Thank you. So again, we have another training mechanism. This mechanism does fall into our traditional grants. This is when their applicant is already in a faculty role. They just cannot have been in a faculty role for more than 5 years. So again, this mechanism supports promising graduate or medical students, but with a focus on people who have already obtained their degree and are in their initial faculty position, focused on psoriatic disease and related comorbidities. They are 1-year awards of $50,000. In FY22, we did award 2 for a $100,000 total commitment, which are keratins as regulators of inflammation and development of psoriasis with Dr. Cohen at the University of Michigan. And then we have investigating the mechanistic role of TNFR2 in the pathophysiology of psoriatic arthritis. And this is Dr. Kaur at Cleveland Clinic. Again, really exciting strides in the psoriatic arthritis space are being made. And Dr. Cohen and the entire team at the University of Michigan are just stellar collaborators and excellent researchers. And then I did want to mention that the Sue Schoenberg Endowment for the Early Career Research Grant was awarded to Dr. Cohen at the University of Michigan. The Sue Schoenberg Endowment for Early Career Research does fund one early career research grant a year, and we are very thankful for the continued support in that mechanism space. If we could go to the next slide. Thank you. So then we have our translational research grants. Translational research grants are these 2-year awards for up to $200,000. It's $100,000 for each year. There is an evaluation at the 1-year mark to ensure sufficient or adequate processes or progress has been made in the research, and this is determined by our research committee. Again, these awards move science from the discovery space, so the preliminary hypothesis space, into clinical, laboratory, or population intervention. So this is where you get your treatments. This is where you go to clinical trial. This is where you start commercializing ideas or doing IP patents. It's really, really exciting because this is where you're actually implementing the research. So we did award one first-year award in FY22. This is B cells and psoriatic arthritis from Dr. Nicole Ward at Vanderbilt University. Dr. Ward was actually an honoree at the most recent gala, which was a Women in Medicine focused, and she is one of the most brilliant mouse model scientists in the psoriatic disease research space. She's wonderful to work with. And then we have 2 projects that are in the 2nd year of funding. So these have been approved for 2nd year release of funds, and they are the role of IL-36 in pustular psoriasis and its female skewing. So this is looking actually at the genetic differences in the presentation of psoriatic arthritis, which is really exciting because it shows the more you learn about the chromosomes, the more you learn about the genetic makeup, and then you can start looking at interventions in that space for implementations. This is for Dr. Sarkar at the University of Michigan. And then we finally have Th9 endothelial crosstalk promotes cardiovascular disease in patients with psoriasis from Dr. Schwartz at UPitt. Dr. Schwartz just finished a fellowship at the NIH and has accepted the first faculty position at the University of Pittsburgh. Again, very, very exciting work in the cardiovascular research space. And I did want to mention that Dr. Sarkar's translational research grant was supported in part by the Dr. Allen Mentor Translational Research Grant endowed funds. If we could advance to the next slide, please. We're going to talk a little bit about the priority research mechanisms of the National Psoriasis Foundation. So the National Psoriasis Foundation is governed by its 5-year strategic plan. The 5-year strategic plan right now runs from 2020 to 2024. So we are approaching the very end of it. As you can see, we have 3 goals they have smaller sub goals in them, but they really drive the organization and the mission of the NPF. So the goal that research falls to is to lead collaborative transformational research. So as you can see, that's 1/3 of the commitment of the NPF strategic mission and vision. So we really are dedicated to moving this science and research forward in the psoriatic disease research space. If we could go to the next slide, please. So here are our sub goals in that leading collaborative transformational research. So we have 4 of them. They are to generate research resulting in higher numbers of patients in remission and identifying tools to extend remission periods. Fund a diagnostic test for psoriatic arthritis that has a broad clinical utility, with the test having been developed, tested, and approved for use. I'm actually about to talk about a priority mechanism directly addressing this goal. Then we have identifying a reliable predictive model for the onset of psoriatic diseases, the potential relationship to comorbid conditions, and the best treatment practices for a cure. This is another space that we're really making some strides in. We're about to roll out some really exciting initiatives. We're not there yet, but we are very, very close. So more to come on that one. And then the last goal here is establish a multi-institutional, multidisciplinary, team-based virtual cluster whose stated aim is to identify an intervention that will prevent the onset of psoriatic disease or related comorbidities. And we will, again, focus on a priority research mechanism addressing that goal as well. These goals that are outlined here enable the NPF to amplify their commitment to priority research funding. So in our priority research space here. So we have 3 active awards in it across 2 mechanisms that we'll talk about in more detail here momentarily. But the NPF allocated over $2 million in competitive renewal funding in these 2 priority research spaces in 2022. So if you look at our total breakdown of the $3.2 million that was funded this year, you can see that's a significant amount of funds going towards the strategic plan and these overarching broad goals that will make major strides in the lives of the psoriatic disease community. We could advance to the next slide. So the first priority mechanism we're going to talk about today, I had mentioned briefly already, but it's the PSA Diagnostic Test Grant. The PSA Diagnostic Test Grant funds research focused on the development of a diagnostic test for psoriatic arthritis that may reduce diagnostic delays and instances of misdiagnoses to lessen the irreversible joint damage seen without appropriate and timely treatment. So a little timeline here. Like I said, we are entering year 4 of the 5-year project. And this one had a little bit of an interesting trajectory because as we saw, research climates had to shift in response to the COVID-19 pandemic. So what happened was in 2019, we did fund the first year of support to establish proof of concept data. 6 projects were funded in this initial proof of concept funding. In 2020, we entered the COVID-19 pandemic, and that was when our competitive renewal was slated to be evaluated for. A competitive renewal means that the initial awardees reapply for funding based on their proof of concept data. The data is reviewed by the peer reviewer, the scientific peer review committee, approved by this research committee, and it goes through a few other levels of evaluation too. But because patients and labs were largely shut down because of staff resources or because time was being reallocated in the rheumatology space to being in the COVID-19 wards, the National Psoriasis Foundation Research Committee and Board of Directors actually voted to extend funding into a second year for all awardees. So instead of narrowing it down from 6 projects to 1 to 2 projects for the second year, all 6 projects did receive an additional $100,000 to continue supporting the labs with the patients not being in them and when their time had to be reallocated elsewhere to give them a fair and reasonable chance to secure that preliminary data to make sure they were best poised to submit for the competitive renewal. After those first 2 years of funding and when labs started reopening or at least adjusting and settling to the unique circumstances associated with the COVID-19 pandemic, we did go ahead and move forward with the competitive renewal process between the 6 projects for up to 3 additional years of funding to confirm their initial findings. These are intended to be followed by development and validation of a diagnostic test, which is where we're at now. And if we could go to the next slide. And here are the 2 awardees who have secured who were recipients of the competitive renewal funding. First, we have Dr. Vinod Chandran out of University Health Network, University of Toronto. And then we have some project information. I know the print is small, but I'm going to go ahead and read it out loud because this is information that we can release about what is happening with the projects, and that's very, very exciting. So for Dr. Chandran, psoriatic arthritis is an inflammatory arthritis condition affecting patients with psoriasis. Due to the varied and non-specific symptoms and signs, psoriatic arthritis is difficult to diagnose. Unfortunately, delayed diagnosis leads to poor outcomes. Diagnostic tests will help facilitate accurate and early diagnosis of PSA. Our previous work, or the lab's previous work in identifying biomarkers for psoriatic arthritis strongly suggests that a diagnostic test or an algorithm for psoriatic arthritis will need to combine easily identified clinical features with biological markers. And these are, genes, gene products, proteins, metabolites into a psoriatic arthritic diagnostic signature. So this means that they are looking for specific biomarkers, so specific genes or proteins within the body that lead to a higher or an increased instance of indicating that a psoriasis patient will develop psoriatic arthritis and then enables to begin treatment earlier and prevent irreversible joint damage. The lab has already verified high priority genes, proteins, and metabolite markers for PSA. Unfortunately, we cannot release what those are at this level of study, but it is very exciting. They're now developing a way to screen for the diagnostic signatures, so the genes and the proteins that we just discussed, that can be implemented in clinics by dermatologists and other clinicians taking care of patients with psoriasis. So for these last few years of the projects here, so years 3 through 5 of the project, they've outlined 3 aims. It's to develop and optimize a prototype targeted assays for the markers identified in the first 2 years of the project. So they're just showing that this can be generalized across the population. They're also going to confirm the discriminatory value of the individual markers and independent sets of samples and analyzing them to develop the integrated diagnostic signatures. So this is taking it and making sure that you can then turn it into a test for it. And then finally, it's the refined prototype assays to clinical grade and create associated online portal to facilitate consistent and accurate interpretation by clinicians. So then now that we've identified these biomarkers, communicating with all the care teams to make sure the appropriate referrals go out, the treatment is started, just constant continuation of care. So at the end of the 3 years, the project will be ready for evaluation in primary care, dermatology, rheumatology clinics. It will have the potential to improve clinical processes by providing means of early diagnosis, limiting the use of unnecessary tests, and thus leading to improved patient-centered psoriatic disease research management. So that is really, really exciting. Our next funded project in this that received the years 3 through 5 competitive renewal funding is Dr. Jose Scher at NYU Langone School of Medicine. Dr. Scher's project, the goal is to define why in nearly 1/3 of psoriasis patients, inflammation progresses from skin to joints, and to identify biomarkers of disease progression from psoriasis to psoriatic arthritis. This is of utmost importance because severe joint inflammation and destruction can only be prevented when patients are treated within the first few months of symptom onset. That number is actually about 6 months. Over the first 3 years of this grant, the team leveraged the multimodal single cell sequencing platform, which is looking at the DNA sequencing and genetic variations, pioneered by the NYU Genome Center in collaboration with Dr. Korolov, who is a stellar statistician, to compare the immune makeup in the blood of the psoriatic disease patients to identify these biomarkers, as well as in synovial fluids in patients with the joint inflammation. So they're looking at a pre-PSA diagnosis and post-PSA diagnosis to see if there are biomarkers in the blood or the synovial fluids at the DNA level. This platform enabled unprecedented insight into differences in immune cells associated with disease progression. So in particular, they did identify a unique subset of T cells and dendritic cells that are correlated with disease progression and are evaluating the potential to use effector molecules and homing ligands and receptors expressed by these immune cells as biomarkers predictive of disease progression. And this is just a long way of saying that they're looking at the DNA and genetic changes in the DNA that may indicate that a psoriasis patient will go on to have psoriatic arthritis, or at least has a higher likelihood. So I did want to briefly acknowledge the first year recipients of this award. So it was Dr. Vinod Chandran, who was a competitive renewal recipient, Dr. Bingjian Feng at University of Utah, Dr. Wilson Liao, who was collaborating closely with Dr. Scher on his project, Dr. Naughton Payne at Rochester, partnering with Dr. Chris Richland, who has recently taken it over, Dr. Ray Chowdhury. If you remember back a few slides ago, Dr. Ray Chowdhury is actually funded in a bridge grant mechanism, and it's actually a continuation of his PSA diagnostic test grant work at the NIH level. So very, very, very exciting. And then of course, Dr. Scher, who was a competitive renewal recipient. I did want to mention that grants not selected for renewal are well positioned to apply for the NIH level additional funding to continue progress based on the proof of concept data gained during the initial NPF $200,000 investment. And that a really good example of that is Dr. Ray Chowdhury, who did apply to the NIH R01 level funding and then is now funded in our bridge grant funding to continue this critical proof of concept data. We can go to the next slide. Okay, so this is our other priority mechanism that has current funding. This is the Psoriasis Prevention Initiative. It's addressing the multi-institutional, multidisciplinary team-based virtual cluster who is intended to prevent the onset of psoriatic disease relapse, or to prevent related comorbidities, because we know that these comorbidities have such an impact on quality of life. So the PPI was launched in 2020, and again, its intended goal was to create or to prevent the onset of psoriatic disease relapse, or related comorbidities. So 1 year proof of concept funding was given to 3 projects. Those 3 projects did go on to have a competitive renewal process, evaluating the progress and future potential of each of the three projects. This was conducted through a very special review. We had a steering committee of experts across the psoriatic disease research space who have driven this initiative through its idea inception to funding the initial projects to the competitive renewal. They are the experts in this field and very well poised to evaluate progress in this space. And then the competitive renewal did award one recipient at $1.5 million a year for up to 5 years. We could go to the next slide. So our competitive renewal recipient was Dr. Joel Gelfand at UPenn. His team includes Dr. Alexis Ogdi at UPenn, Dr. Renad Bedas at UPenn, Dr. Nehal Mehta at NIH, at the NIH, and then Dr. Armstrong at USC. So then we do have a summary of progress on this one. This project is focused on cardiovascular disease. So I'll go ahead and read this out loud again because I know that text is pretty small. So psoriasis is associated with an increased risk of cardiovascular disease, including heart attack, stroke, and premature death. Recommendations from the National Psoriasis Foundation, American Academy of Dermatology, and the American Heart Association, American College of Cardiology, list psoriatic disease as a risk enhancer for cardiovascular disease. Despite the increased risk of cardiovascular disease and recommendations from professional societies, people with psoriatic disease are more likely to have underdiagnosed and undertreated cardiovascular risk factors such as high blood pressure and high cholesterol, resulting in preventable premature mortality. To improve the health and the lifespan of people living with psoriatic disease, we involved the team involved dermatologists, rheumatologists, cardiologists, patients, and implementation scientists to achieve 2 goals. The first goal is to determine barriers and facilitators for implementation of cardiovascular prevention care in patients with psoriatic disease. And then the second goal is to design and plan a clinical trial that will test dermatologist and our rheumatologist screening and management of CVD based on treatment guidelines and goals of statin utilization in patients and with psoriatic disease compared to baseline care. So what this means is that they are implementing a best practices screening model that would be administered at the dermatology or rheumatology level, and then creating a care coordination model to make sure that psoriatic disease patients are being connected with the appropriate resources and providers to treat this unmet need in the psoriatic disease community, focusing on a cardiovascular disease and the increased mortality associated with it. So they did have a lot of input from provider and patient steering committees, and the NPF is actually a subcontractor on this award, meaning that we are providing services in part of the care coordination model and partnering in these initiatives with Dr. Gelfand and his lab. So the overarching goal of this project is to actually increase the lifespan and the health of individuals with psoriatic disease. And this would be accomplished by focusing on the screening of the traditional cardiovascular risk factors by dermatologists and rheumatologists in the context of providing care for the skin and or joints while developing a novel care coordination model, including a centrally located care coordinator provided by the National Psoriasis Foundation. Based on these findings, there was a 1-year pilot and a 3-year clinical trial to the PPI to further assess and evaluate a care coordination model. We have just completed the 1-year pilot project, and we'll be moving forward with the 3-year clinical trial to further assess this care coordination model. And we're excited to continuing partnering with UPenn and supporting this study, utilizing not only the National Psoriasis Foundation investment, but also our partnership through staff and care coordination resources. If we could go ahead to the next slide. Thank you. So now these last few minutes here, we're going to focus really specifically on the More Than Skin Deep Mental Health Grant, which, as you guys know, or as you may know, is the theme of World Psoriasis Day, which is coming up next week on October 29th, and is the theme of today's community conference. The intent of this mechanism is the increased incidence of mental health disorders in persons with psoriatic disease, which has been attributed to increased stressors of living with chronic disease, social stigma associated with disease, and evidence that inflammatory processes in psoriatic disease may also create neurological changes affecting mental health. So this is a long way of saying that we are targeting mental health at all levels. So we're looking at the stigma, we're looking at the self-perception, we're looking at the inflammatory processes and how that infects the brain neurologically. We're looking at how hormone output or stress responses come out. We're looking at every way to address this intervention, which is really, really exciting because it is such an intricate, mental health in general is such an intricate area to focus in, and it's such an important area to focus in. So data suggests that mental health in the psoriatic disease community is not appropriately addressed. We can go ahead to the next slide. So here I have some statistics from the NPF annual survey. If you're not familiar with the annual survey, this is a survey that goes out each year to the psoriatic disease patient community. I believe it goes out to about 60,000 constituents that are randomly suggested or randomly screened. George Gondo, who is the Associate Director of Research on our team, oversees this initiative, and we're really excited to get it rolled out for this upcoming year. But here are some statistics about mental health in the psoriatic disease population. So for depression, 20.7% of the 2019 annual survey respondents diagnosed with psoriatic disease suffered from moderate to severe depression. This is compared with an only 7.1% prevalence in the general population of the United States, according to the NIH statistics. So as you can see, this is an over 13% increase from the general population to psoriatic disease population. Anxiety. So data suggests that anywhere from 1.81% to 22.7% of persons with psoriasis experience anxiety, and this is compared to 1.35% to 11.1% prevalence in the general population, which is almost it's almost double. So very, very important to look at all mental health, including depression, anxiety, stigma, barriers to care. If we could go to the next slide, please. So a few more statistics from our annual survey. Suicide. A systematic review of 18 studies found that patients with psoriasis were twice as likely to consider suicide, with a 30% higher likelihood of attempting suicide and a 20% higher likelihood of completing suicide. Then there's stigmatization, which may exacerbate self-perception, negative emotions, and maladaptive thought processes. A recently published report entitled Mental Health and Skin Disease showed stigmatization, discrimination, and lack of social acceptance and understanding is experienced daily by some psoriatic disease patients. This can also contribute to avoidance behavior and the feelings of isolation. So patients may not be comfortable going out if the skin surface area is greater. They may be uncomfortable with flakiness of the scalp, and these are they can contribute to people not being comfortable going out in public or interacting or shaking hands. It can create a lot of anxiety, a lot of stress. And this doesn't even take into effect the increased medical and financial burden of having chronic illness. And then, of course, the steps to address these barriers to care. We can go to the next slide. Okay, so now we get to the More Than Skin Deep Mental Health Grant, which I have mentioned. So the More Than Skin Deep Mental Health Grant supports this area of unmet need in the psoriatic disease community by funding research focused on, but not limited to, the investigation of psoriatic disease on mental health, as well as addressing interventions for addressing the comorbidity, inflammatory processes, stigma, psychosocial impact of psoriasis, barriers to care, financial burden of chronic disease, or other related areas. So all this is to say is we are not looking at any single area of mental health. We are looking at overarching mental health. We are committed to addressing the inflammatory impacts, the financial impacts, the anxiety and depression impacts. We are looking everywhere in order to support our psoriatic disease patient community. In FY22, we did award one award at the amount of $100,000. This award was Depression and Anxiety in Psoriasis, Mechanisms of Action. So this is targeting at the basic science level, looking at the inflammatory impact on the body. And this was awarded to Dr. Stahl at Karolinska Institute. This, I do want to say that the More Than Skin Deep Mental Health Grant was made possible by significant contributions from the Fairfield County's Community Foundation, the Fred and Joan Wiseman Fund, and the Thomas Andrew Spiegler Memorial Fund. Again, we could not fund any of this research without donor funds and the support that we receive from our community. We are very thankful for this continued support. And we can go to the next slide. So we did 2021 was the first year that the National Psoriasis Foundation rolled out this More Than Skin Deep mental health mechanism. This was in response to the COVID-19 pandemic, exacerbating this critical need for mental health research. So this was a $300,000 commitment in our initial rollout. The awards were evaluating the impact of sleep on psoriasis and mental health. This is Dr. Butani at the University of California, San Francisco. We have mental health and inflammatory determinants of neuroconnectivity as predictors of treatment response in psoriatic disease. And this is Dr. Haberman at NYU Langone. So this is, again, looking at the inflammatory processes in the brain and how treatment response is either a barrier or a supplement in reducing the inflammation and thus reducing the impact of mental health burden in psoriasis. And then we have the third, which is Mind Matters, a high-touch, low-cost approach to improving mental health outcomes in patients with psoriatic diseases. And this is Dr. Husby at Cleveland Clinic. And then again, this grant was made possible by significant contributions from the Fairfield County Community Foundation, the Fred and Joan Wiseman Fund, and the Thomas Andrew Spiegler Memorial Fund. We can go to the next slide. So I know we have about 15 more minutes here, or I guess about 18 more minutes. So I'm going to go ahead and open up the floor to questions about our funded research. Again, I cannot release any progress reporting or proprietary information on the research results that are disseminated, but I'm happy to take questions about any of our mechanisms or provide some guidance about where the NPF is going. So if there are any questions, please feel free to unmute yourself or to drop them in the chat. And Jane, if there are questions that come through the chat, would you mind reading them aloud to me because I cannot actually see it?
Sure.
Thank you.
And I'd like to lead it off with, thank you, Jess, but I was wondering, is there a place where people could look for articles on those different grants from FY22?
Actually, we are very excited to announce that we did just release a funded research profile with the FY22 awards. A formal email is going to go out in a week about this, but there is on our site an active research portfolio, and it's really exciting because it has the names and the titles of each award, the terms of each award, and then it has a brief description of the award. So you can actually find a summary, a general audience summary. So that means a summary written for the patient community that is able to break down what is going on in the award in more detail than we had in our time today.
Great. Oh, it looks like Audrey just put a link in the chat. So thank you, Audrey. And Nadine has a question. What is the progress on psoriatic arthritis biomarkers at the University of Toronto?
So I cannot comment specifically on any of the results they've making, but they have identified specific biomarkers and they are working with imaging studies to continue identifying these. Like we are in year 4 of a 5-year funding, and they are expected to have a commercialized either intellectual property or patented diagnostic test by the end of the 5th year, which concludes June 30th, 2024. So at that point, we'll be able to release a little bit more about it. But right now it is still proprietary and we cannot release on behalf of the institution.
Well, that's exciting that it is coming down the pike pretty quickly.
It is. We are really excited that we've completed these first 3 years of funding and we're entering the 4th year. We have some very strong preliminary data and we're very excited to address this critical need in the community.
Yeah, and the community is responding in the chat. With great, thanks, yay!
Oh, wonderful. We love to hear that.
And a nice big smiley face from Nadine.
Do we have any more questions?
I don't see any in the chat. Does anyone have any others that they'd like to put in or unmute themselves? Nothing is
Okay.
popping up. So
If there are any further questions, I'm happy to share my direct email in the chat. I'll go ahead and drop that in here in a second, or so please feel free to reach out and I'm happy to provide what information I can. We do have that funded research portfolio on the website with the most information that we can give out about our projects, but we're happy to engage more. And if you have ideas about where you would like to see psoriatic disease research go, or barriers that the National Psoriasis Foundation is not currently addressing, we're always open to the feedback. We will be rebuilding our next strategic plan here soon, and we would love to align our research initiatives with, of course, the needs of the psoriatic disease patient community, because really everything we do keeps the psoriatic disease patient community at the forefront of our mind and our funding process. And I just wanted to comment on that briefly to reaffirm that the psoriatic disease community is at the forefront of the process. So the way our review works is we have a really excellent committee of scientific peer reviewers. They screen for the science of the awards. They also triage to make sure the awards are indeed related to psoriatic disease and that they're not broader to other or generalized to other skin conditions or dermatological conditions. But after we go through the science, so that, is our first 2 rounds of the process, we go to this research committee stage. The research committee stage is really exciting because the research committee, as Jason discussed earlier, is comprised of a psoriatic disease research patient constituents, and they are actually intended to screen and align our research with the needs of the psoriatic disease patient community. So the rankings come in of how the science is from our expert panelists that are aligned to the expertises of the grants, and then the patients come in and they say, hey, I think this would be great, or this might not be where we need the science to go. So the patients really do have this final say to make sure that we are aligning with the mission and the vision of the NPF strategic plan and the patient community. So everything we do, we are keeping the psoriatic disease community at the forefront of our mind in, each and every day. And we love feedback. We love to continue connecting, and we love to continue these conversations about how we can grow our funded research portfolio. So if you have thoughts, happy to set up information and calls about that.
there's one thought for research. Tammy said she'd love to see research on enthesitis.
Okay. I think that would also be great. We'll see what applications come in. Applications actually just opened for this upcoming funding cycle last Friday. So we're really excited. They're due on January 15th. Unfortunately, we can't determine what comes in, but I also think that would be very, very exciting. We do have research on anti-inflammatory diet and psoriasis. This research is fewer. The reason that it is not as broadly funded is because it has a lot to do with adherence to a diet. There's no way to research and make sure that patients are adhering to these diet regimens. So researchers can say, please eat these foods or foods in these groups, that they can't ensure people are doing it. And because there's so much variation in that, results are skewed. But of course, anti-inflammatory diet can reduce inflammation. Psoriasis is an immune modulated condition. It has systemic inflammation, which means inflammation at the whole body level. It involves the organs. It is more than skin deep. So there is evidence suggesting that an anti-inflammatory diet can reduce the burden of psoriasis, but it is in, combination with effective treatment regimens and care with your care team and your provider. And yes, we have fantastic podcasts for the patient community about a myriad of topics relating to care and treatment, as Bev so kindly dropped in the chat.
I think the questions have slowed down and the ideas. And thank you very much, Jeff. Jason, are you still around to lead us?
I am here. I'm in transit, so hopefully I continue to hold this connection. But yes, no, thank you, Jess. That was excellent way to see all the a lot of the research the NPF is funding and the progress that we're making. And thank you very much.
Thank you all for having me. Thank you to everybody for putting this on.
All right, so I think for now we will move into just some announcements, and then what everyone says is their favorite part of these community meetings is the social hour. So I want to thank you all for attending this Healthier Together. It's More Than Skin Deep Community Conference. Before we move to the social portion of the day, however, just a few items we need to mention. Conference has been recorded and will be available on the NPF website soon. Please consider volunteering with the NPF, deepening connections to the NPF and the psoriatic disease community. We'll be sending out a survey next week. Please give us a feedback. We want to know what you thought of the conference, good, bad, other things you'd like to see included. This really is for the community. So your opinions are really, really the most valuable part of this. We also want to thank our sponsor, Bristol Myers Squibb. With their support, the NPF can continue to provide conferences like this for our community. And so we are very, very thankful to Bristol Myers Squibb for their participation today. And so we want to thank you for attending. We look forward to seeing you in person at our next community conference, April 22nd, 2023 in, Alexandria, Virginia. More details and links to register will be available early in 2023. So thank you all for attending today. We're going to leave the Zoom conference open for about another half hour, maybe a little bit longer if people are on. If you want to unmute your microphone, say hi or hello to attendees across the country today.
And put your cameras on if you'd like.
All right. And I want to thank everyone who's participated and presented as well. But more importantly, thank you to all of you for being here. And we will see you in April.
Thank you, Jason, for taking the time to be our wonderful host and MC for today.
It was my pleasure, and I'm glad everything worked out. It's a beautiful day here, and hopefully you all have beautiful days across the country as well.
Thank you, Jason. Hi, Jason. It's Tammy.
Hi, Tammy.
Hey, Tammy.
Hi, Hi, Katie. Are you in the hospital again?
Yes, pardon the beeping in the background. My IV ended like a half an hour ago and they haven't been in to shut it off yet. So I'm going to be like intermittently muting myself. It's just the legs just keep getting reinfected.
Yeah.
I'm so sorry. I didn't
Yeah.
know you were back in.
I only came back in, I guess I've been here a day and a half. So, and my biggest issue was this thing invaded the psoriasis and just getting the people to coordinate with my dermatologist to take care of that portion of it. And I mean, I've managed to convince the infectious diseases people to work with him, but not wound care. And they're finally saying, oh yeah, you need to follow up with your dermatologist. I'm like, I have been. Maybe, you know, you should bring him in and, you know, you got his number. So we'll see.
Well, care coordination is challenging, you know, for lots of people. And I think in particular, when there's chronic things that we're managing combined with acute episodes, it's really challenging because the system it's not well designed for any sort of collaborative care between healthcare practitioners to begin with. And then you add in kind of, you know, we're just starting, I think, with, you know, rheumatologists and dermatologists to get good collaboration across these specialties that have this overlap in chronic disease, but the connection between the folks that deal with acute issues, you know, those emergency situations, and those that deal with the chronic stuff is nowhere near that far along.
I'm in a far better position now, Leah, than I was when this first started. When my first admission was in February, and I would say psoriasis to my doctors, and they'd be like, "What?"
Well, that's why we've
So-
started a medical school curriculum. So we're 800 medical students into educating them about psoriatic disease. So regardless of what they go into, they'll hopefully know more than they're getting right now through their medical school experience. But that's terrible that you had to educate them.
Yeah, I mean, and that I've been probably more grateful to the foundation this year than I have been, and well, since forever. But I mean, just because I've been able to say this, and this, and go to psoriasis.org. There's a whole slew of stuff just for medical professionals on the Psoriasis Foundation website.
Yeah.
And I mean, and like I said, just more recently, like I said, managed to get the infectious diseases folks, because I mean, basically the infection is invading my psoriasis on my legs. And I've been able to manage to get them to consult my dermatologist and get stuff coordinated with him, and they are doing better. I've actually now got nurses and asking me questions and talking to me, and being able to give them the information now that I just know right off the top of my head because I've educated myself through the foundation. And in my last admission, I actually had one of my nurses say that her husband was recently diagnosed with it and he was still in the whole angry stage. And I'm like, listen, this is what, if he's refusing to deal with it, this is what you can do as his spouse.
Yeah.
And just been able to, so like I said, we've come a long way, but we're still not, to that point of getting a whole collaboration of care yet.
Yeah, it sounds like you were having to mentor the nurse, which is not exactly what our one-to-one program is about, but good on you for doing that, Katie. I wonder, Bev and Jane, I will admit I don't know the answer to this. Have we ever done a Sound Bites episode on like wound care and anything kind of talking about this issue, infectious disease and psoriasis and wounds? Because that I think would be a really good podcast topic.
I haven't done one, but I wouldn't be opposed to it, but I'm not sure how good I'd be just yet, because like I said, I'm still going through it.
Yeah.
So.
Well, I mean, I think your experience, it's it definitely is highlighting the need for additional resources in this very specific area. I see Jane's writing. So I think we've given her and Bev an idea of a topic we can cover. And I mean, I think it's a really important point that, you've got to have kind of that working understanding as a healthcare professional about these issues. Otherwise, the specific guidance is challenging to give when you have someone who's trying to manage a disease that overlaps with the area of the body you're trying to treat.
Yeah.
I don't know, Jason is still with us, but I don't know if you have any thoughts as a provider of what Katie's talking about.
I would actually even go so far as to say that my dermatologist would probably be very willing to even go in on this with me. He does a little bit of volunteering down here for the foundation. That's how I found it. So
who's your dermatologist,
I
Katie?
probably would say we could probably enlist him to help with this also.
Who is your dermatologist? Oh.
It's muted.
Katie, did you hear me?
Katie, you're on mute.
Darn computers.
Yeah, like I said, I've got the beeping on in the background.
That's okay.
My IV's on it, and nobody's coming to shut it off yet. So.
What I was going to add, following from what Leah said, obviously, I come as a plastic surgeon, which is why I was excited by the aesthetic book, but and my connection to the psoriasis community is personal rather than professional. But you see it all the time, and we see patients who come in, and you will always have to be your best advocate to your doctor. Now, because I'll see a patient come in and they'll say, I've got Smith disease, whatever, something that I heard about in medical school a few years ago, or these things you have a vague understanding of, and those things and those rare diseases, patients are always going to be the person in the room. Once you've lived with that disease for a little bit of time, that patient is always the biggest expert. What we shouldn't have is a disease as prevalent as psoriasis, where providers are going, oh, I have something, whatever. And I think the work the NPF has done in terms of educating medical students, medical student curriculum, is really beneficial. I mean, when we, this is a lay population piece of it, but when we did our first run in Columbus, we got a call from the chief of police, and he's like, and we were doing this, my son was 9 at the time, 9 or 10. And yeah, he's like, I'm here to do detail for your cirrhosis run. And I'm like, I really hope my 9-year-old doesn't have cirrhosis, but, and that, so, but that piece of raising awareness is, I mean, I know we talked before about fundraising, but the awareness that we were able to raise with the run really was a great piece of it. But in the healthcare setting, like I said, you will, for the most part, you'll find when you have a chronic disease, when you go to your doctor, they should know a lot. You will often know more. With psoriasis, it's prevalent enough that, as physicians, if we, don't know what psoriasis is, then we are not doing our jobs.
Yeah, and I would go so far as to say that in addition to the infectious disease part, and I'm sure Katie can be right on this with me, is that, if you go into an emergency room, they don't always pay attention. They don't always listen. I ended up in the hospital for 3 days and almost died from malignant otitis because I had an ear infection on cyclosporin. The PAs at the emergency room, 3 different emergency trips, had no idea that cyclosporin could do anything to your immune system. When I was finally admitted, I had a Pseudomonas infection, and they told me that I had a yeast infection in my ears. And I said, I have psoriasis in my ears. And they said, there's no such thing. And then I had an ear, nose, and throat doctor come in, and she said, well, this yeast infection in your ears. And I said, I don't have a yeast infection in my ears. I have psoriasis. And they're like, there's no such thing. And I mean, it backed up my care, because they were giving me antibiotics in the emergency room that made me resistant to antibiotics. So I went through 14 different IV antibiotics before they figured something out that would help. And it could have all been avoided had the first doctor said, I don't understand the cyclosporin thing. I mean, because if somebody comes in with an organ transplant, shouldn't people know what cyclosporin is? I mean, shouldn't that be a normal thing? And it wasn't, nor does psoriasis in your ears exist, according to all the doctors that I had at the time.
And
Yeah, well, go ahead, Katie.
I was gonna say, that's the problem that I keep running into, is the resistance. That I'm now waiting on wound care to come in and do another culture so they can specify the correct antibiotic. And getting on to, because obviously this came in with a flare of my psoriasis, and that's how it invaded. So it's getting on the correct treatment for my psoriasis. I'm now on Cosentyx, which has previously worked for me, but is not currently working. And I'm not sure if it's because the infections are so bad, or if it's conflicting with the other medications. But I've yet to run into the problem of, psoriasis in your ears doesn't exist yet, but they're not looking at my ears, they're looking at my legs. So
Yeah, well, we will keep rooting for you. Please keep us posted. Connect with Audrey or Jane or Bev, somebody on the NPF team, so we can keep an eye on you and hear how you're doing. And I do think, it would be great to chat offline about who your dermatologist is, and if there's some more conversation we can have with them about how, we can share additional information with providers about this issue. So let's definitely follow up with Katie when she's in a position to have that conversation, because I think you're really highlighting for our team an important area of education. And I think, we've been talking a lot over the last few months about infectious disease, right? Not just the pandemic, but monkeypox even more recently. And there's been a lot of question about psoriasis and how it relates to monkeypox. And so we've been trying to answer those questions. We've done education of a lot of reporters on that topic. And so they've been able to write some stories to help clarify for people, what monkeypox is versus psoriasis versus eczema. But I think this is another really important issue. And I think what we're seeing overall in the healthcare system right now is an increase in infections just generally. I just read this article this week on how RSV, which is a very common respiratory virus that anyone can get, but kids tend to have a lot of challenges with it, is really spiking right now. And that the ER utilization in the DC area, at least for RSV, is at levels they never see at this time of year. And it in part is because people are getting back out there and they're interacting, and we're all, sharing germs again, and people just, the bodies, back to Dr. Fried's point about, our bodies are kind of being immunized every day, through lots of different interactions with different bacteria and other things. But I think kids just weren't used to that virus. And so there's RSV has been going around. Hand, foot, and mouth is something a whole bunch of daycares have had in the DC area. And so I'm not surprised that people are asking a lot more questions about infection issues and, some of these other considerations. So the team will connect on how we can do some education around that topic.
I should say
Piggyback on that. Sorry.
That's the other part.
I was going to briefly just.
We're talking over each other now.
You go, Katie. You go. You.
I was going to say that's the other part I'm grateful for, is that, Audrey's been checking in with me. Chris was checking in with me. Chuck down here has been checking in with me. So, not only am I connected to a lot of the other volunteers, I'm being connected to the staff who are checking in with me. After my first hospitalization, the first card I got was from Audrey. And so I was practically in tears when I got that. So, very, very grateful.
Well,
I was simply gonna piggyback on what Leo said. This is my opinion, not NP. Well, I'm sure NPF too. So it's time for your flu shot if you haven't gotten it, because we haven't seen it because of masks and everything else. This is my medical opinion, my plastic surgery medical opinion. Flu will probably be bad. So if you haven't gotten your flu shot, please consider it.
Mm-hmm. And Katie, I
thank you, Jason. We have done some promotions about the flu shot in the past, and we might need to do. I lost my light here. Yeah, we might need to do some of that again. So,
yeah, and it's sad as a doctor to say we have to sort of tiptoe over saying that, but yes, I don't care. I don't care about tiptoeing.
I'll tell you the one thing that I guess COVID and the whole shebang has done for me is, I've always got my flu shot, but I keep getting my boosters. I'm scheduled now for my shingles shot. I'm getting ready to update my tetanus. I'm just getting ready, you know, I'm like, let's just get them all and have them done with. And then they're done. Then I don't have to worry about them anymore.
Don't you have a conference to present at, Tammy, coming up?
I do, which is what prompted, because I've been going back over a lot of this since you and I got together, and I will be presenting, I will be part of a breakfast panel at the American College of Rheumatology on November 13th regarding enthesitis. And when Audrey contacted me, and then I was getting ready to talk to Tyler about it, I started going through all my stuff, and I was just like flipping through my diagnoses on my my app, from plantar fasciitis to bursitis to spraining the inside of both my ankles at the same time, to this, to that, to myalgia, lower back pain, elbow pain, tennis elbow, to everything. And it just made me so mad, because one day my rheumatologist got tired of dealing with me, and she sent me to a pain doctor, and the pain doctor said, well, what are they doing about your enthesitis? And I was like, what is that? And she's like, well, that is all of this. So that was kind of a revelation. So I said to my dermatologist, I was like, you know, do these all go together? And he said, they absolutely do. Now, my dermatologist, he is an educator for the National Psoriasis Foundation. He's a member. He does a lot of stuff. He's not in my group of doctors in my hospital system. He's from when I lived at my old place. So he did not see all of this because my rheumatologist didn't send it to him. So I like screenshotted the list and sent it to him, and he said, oh, Tina, that's all enthesitis. What, you know, I mean, that's all. And I'm like, you know, that had been going on for 8 years before I got diagnosed with PSA. And everybody said I was called a drug seeker. I was called a faker. I was called a hypochondriac. I was told that from rheumatologist that she felt that my pain was not what I claimed it was. And it's so frustrating. And so I've just been really, really thinking about this with this conference coming up. And you know what? It honestly made me mad all over again. Because I'm like, nobody was paying attention. And my rheumatologist told me, you don't get enthesitis with psoriatic arthritis. And I was like, I pulled up, I was in her office and I pulled up the MPF thing on enthesitis. And I was like, well, look here. And she said, how dare you second guess me? Who do you think you are to tell me? And I said, well, we're not going to talk about it anymore. And I got up and walked out and haven't had a rheumatologist since.
Well, you're going to have a room full of them. So you'll have a captive audience, Tammy. I think you can do some really important work at this conference.
Yeah, I think so. And I think it's something that, because so many people don't know what it is. I didn't know what it was. I didn't know what it was for years until it was something that I just like kind of was like, yeah, whatever, inflammation, blah, 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 blah. And I was like, yeah, inflammation, you know, I mean, I know it, but they kept telling me that this was different stuff. And I kept believing until just one person said, just offhandedly, well, what about this? Well, what are they doing with this? And it just, it stopped me. So this has been like, and then to find out that like a third of us to a half of us have enthesitis with psoriatic arthritis. And for a lot of us, it is the most, I know for me, it's the most painful symptom. I mean, it's excruciating. When they told me that I sprained the inside of both my ankles, I mean, I I had trouble getting out of bed in the morning. It took 6 weeks for it to clear up. Nobody was treating it. It took 6 weeks. I couldn't even sleep with a sheet over my feet. The pain was so bad. I was going up and down steps on my butt. You know, it was, and people just like send you off. Okay, yeah, whatever. Well, it's not this, so we don't know. So go do your thing. And not realizing that you have to go home. Like Katie, you have to go home and you still have to deal with this. It's not, it doesn't just go away because it goes away for one person. It doesn't go away for the person having it because the person that should be treating it doesn't know what it is. And so I think that's something that we need to make a good push for awareness is because it is so painful and it is so frequently misdiagnosed.
Yeah. And you just made a very good point, Tammy, that there's, even though it may be something that we know about or you know about now, how many people out there in the world do not know about it? And so that's why we're continually having to go with that education for everybody. Never
And that
stop.
is, yeah, when I talked to Tyler about this, this panel, and I said something about my dermatologist, and he said, you know, we're speaking to rheumatologists about this. He says, but you know, we need to start looking at dermatologists about this because that's who's going to see this first. They're going to see people before they're diagnosed. And because this is frequently one of the earliest symptoms, we need to look into talking to dermatologists about this and make them aware that patients with psoriasis, if they start complaining about this, that, I mean, because as a patient, you don't know, I just hurt.
Yep.
I don't know that it's my joints and or my ligaments and tendons where they insert in the bone. I just know it hurts.
Very good point that Tyler made. Not just the rheums, but the derms too. So good.
I don't want to cut into people's time, but I see Sandy is here from Virginia and Nadine is here from, or Nadine, depends on how, from Canada. We actually had 2 international constituents visiting us today. Natalie, who was on, was from the UK, and Nadine is here from Toronto. So that's pretty cool.
Toronto, no wonder you were interested about the research in Toronto, Nadine. That's fabulous.
Hi,
For what-
everyone.
Yeah, for what it's worth, I'm a graduate of the University of Toronto.
Oh, then why did you leave?
Right now, so that's why I'm not on camera, but I'm listening intently.
It's so good to have you here, Sandy and Nadine. Welcome.
You know, I just want to mention something. I haven't officially been diagnosed, but I am in the process of seeing a dermatologist. But I've taken pictures of my symptoms. It's like, you know, a scalp psoriasis. But, you know, I've had this condition for years, and really it wasn't anyone who gave me advice over the years. I would always have an itchy scalp and I would have like, I felt burning. And it wasn't until I saw a hair stylist who was coloring my hair, and she saw my scalp and she says, oh, she says, you better go across the street to the health food store. We have these like natural pharmacies. And she said, and get like a psoriasis shampoo. She says, like, your whole scalp is covered. And I was very stressed with work. So like over the years, I let my health, you know, just like I took it for granted. And then I was in a car accident, and that's why the psoriasis has come back. So I'm interested in more, like, you know, more research. I have arthritis, but it's been diagnosed as osteoarthritis. So I just wonder if there is some psoriatic arthritis possibly as well.
And there is that possibility. I see, Nadine, that you're connected with one of the navigators here, so that's excellent. We've got a lot of good resources if you need more.
Okay, thank you.
Mm-hmm.
All right. Well, I'm gonna jump off. Please stay. I want to thank you all for coming. This is really you know, the research we heard about is amazing, but really, and the funding that the NPF does is a huge piece of it. But to me, really, the community that it builds. When we came to the NPF because we wanted Sam when he was 9 to know that he wasn't alone, and so the community here, that to me is really the biggest part of what the NPF does. So you guys being here, I thank you all for that. And everyone be well, and we'll see you in April or before.
Thanks,
Thank
Jason.
you, Jason. We
Thanks,
appreciate
Jason. It was nice
Yeah.
seeing you. Great job today.
Good seeing you too. Thank you.
Thank you, Jason.
Absolutely. Everybody be well. Katie, get well soon.
Thank you.
Kathleen is back.
Sorry, I've been having issues.
Hey,
Oh.
Kathleen.
Hi, Kathleen.
Computers are the bane of our life, aren't they, with all these issues lately?
Oh, goodness, thank you. But I look forward to the recording, though.
Well, we will have the recording, so that'll be great.
It's
Thank you.
nice, the recording is indexed, so if you might have seen a presentation but didn't see another, you can kind of scoot by it. It's pretty handy.
Perfect.
Yeah. Hi, Michelle. How's the VIA? You guys busy this fall? Lots of activities, sports, that type of thing?
Oh, can't hear you, Michelle. Oh. Write it down, put it up.
Stephen, you're just back from some travels, right?
Yeah, I got back on October 4th from the Philippines. I was in the Philippines for 3.5 weeks.
What were you
I've
doing?
actually, what was I doing there?
Yeah.
Well, a number of things. I served in the Philippines. Now it's a long time ago now. But in any case, I served there, and I also got married there. We were going to be going back around December, but one of my wife's brothers developed lung cancer. So we went back early so she could see him. He's thankfully responding well to treatment. Other than seeing him and members of her family, went scuba diving, went swimming with whale sharks, and saw old friends from when I had served there. It was a good trip. Yeah, the only thing wrong with the trip was that I've been doing too much traveling of late, because in July we went to the UK because my oldest son was graduating from the London School of Economics, and I planned that in February. And then this trip, we changed it from December to September. And then a friend of mine in Canada, who I knew from when I was at the University of Toronto, he's from Nova Scotia. And he said, hey, I'm going to be traveling around Nova Scotia in August. Want to join me? And, so ended up having 3 trips in 3 months. They were all good trips in and of themselves, but it was just a little bit too much. And right now, I'm not at all enthusiastic about traveling for anything that takes more than a weekend or 2.
Well, Virginia in April. I mean, that's your backyard.
It's such a long commute for me. I don't know if I can make that distance.
Listen, I just messaged Stephen and said, should have a bird watching, have some eagle watching, because all of our advocacy meetings, he gives us pictures. We should have a field trip during the conference.
Well, my kayak.
Yeah, no, for everybody who's still on this call and for anyone who's not, you're all always welcome to my place to go out kayaking. I've got 2 one-person kayaks, 1 2-person kayak, and a 3-person flat-bottomed canoe. So if we need more than that, yes, you do have to bring your own means of transportation, but I can handle a fair number of people. And you can, if there's a conference, that's fine. We can, include that within the conference. But also, if people are in the area and they just want to do it, they just should let me know a few days in advance. And depending on the gods of weather, we'll go out.
Sounds
I'm really
great.
looking forward to the conference. We wanted to put this one to rest before we moved on, really thinking a lot about the next one, but always looking for topics. What's really speaking to you? What would be interesting? I mean, we learned a lot from the one previously, and thought the pairing of different doctors was really cool. And it's just going to be fun to put this together. But if you have ideas, please let us know.
Well, I have an idea, but it's not for particular subjects to cover. I will be, going to this one in person, given the long distance. For the Chicago one, you did not have a remote option. And I would strongly advise that for all conferences, and you notice I said the word all, okay, unless there's something confidential that you don't want it to be shared amongst more than a small group, they should all have both an in-person and a remote option.
It's something that we'll certainly think about. Yeah.
Yeah, because I mean, if people have the resources or time, they will go in person. But if they don't, why not let them participate however they can? For example, when I was in the Philippines, because I also do some local volunteer work, and there was a meeting of the board of directors of an organization that I serve on, and I participated from Manila. So, give people the option to participate wherever they are in the world.
Yeah. It's interesting. So what time would it be for the woman, Natalie, who joined us earlier? Is it 8 hours to the UK?
8 or 9, depending on whether we're daytime, daylight, or
Wow.
not.
Well, obviously, given the time differences, some people will not participate. It's a question of giving them an option.
Of course.
And again, when I was in the Philippines, I was initially not planning on participating. Their meeting was at 8:30 in the morning, which was 8:30 in the evening. But just so it happened, I didn't have anything that I was doing at 8:30 in the evening, so I did participate.
I would second that too, because traveling this year has not really been an option. So, being able to participate, I would have loved to have gone to Chicago, but
Yeah.
it just
And
couldn't happen.
yeah, no, and many people in the NPF have medical issues. I mean, that's why we're in the NPF.
That's why we're still continuing to do the virtual conferences too.
Yeah, but I can't think of any reason why we can't combine the two.
Yeah.
Or maybe I should rephrase that, any good reason.
Cost is always something we need to look at, because it is rather expensive to include a virtual option with an in-person conference. So it is something we always have to take into consideration when we look at these.
Okay, that's a fair point. But again, it could perhaps be recorded and shared with people, even if it's not a perfect recording. It could be somebody back there with their cell phone taking a recording of it. Mm-hmm. Or it's something of that sort done in an inexpensive way. Get somebody's son or daughter to hook things up.
We get a lot of these conferences. Sometimes there's not a lot of people here, but Bev provided me some information. There's a lot of post-conference views. So like last October, we had a meeting that had 44 views. The month before that, in March 2021, there were 304 views. So it really does have a lasting impact, even if we don't have a lot of people at the conference.
It was fun doing the however you say. Again, that was a lot of fun.
So you do that in your own time now?
I do. Yeah. Yeah. I got a little bit hooked on it when I was at the conference, and the speakers at the last conference, they were all fantastic. I mean, they were so good.
We were so grateful to get Dr. Stein to do the podcast.
Yeah, it was awesome. And I also got my chance to fangirl over Jonathan Scott. So, there's always that.
How the Steelers doing, Tammy? Any good this year?
Oh my God, we're terrible.
Oh,
They beat
the
the
worst.
Buccaneers.
I know, we beat
I was
the
very
Braves.
excited about that.
I went, we didn't go to the game, but we went and helped. We're friends with a Steeler from the 90s with Ray Seals, and he lives in Tampa, and he comes up every so often and does tailgates. So we went and helped serve at the tailgate. And then they have a DJ that brings the television. So we sat outside the stadium and watched it on TV. And it was just so cool because there was a little bit of a delay. So we'd be sitting there watching a play, and all of a sudden you'd hear cheering from the stadium. And we'd be like, oh, something good's gonna happen. But it was a lot of fun. And it was because I usually go to before the Patriots games and now the Buccaneers games. And we always lose to him. So it was just so exciting to win. Even it's only the second game we've won this year, but it was a great one to win.
It's not the quantity, it's the quality.
And so far, that's been the only Steeler game that they've shown locally. So, gotta be grateful when they play the Buccaneers.
I want to pass on something to the NPF staffers on the call.
Yeah.
I multitask. So one of the things I'm doing right now is also looking at some emails. And I'm looking at an NPF Advanced Weekly that was sent to me on Tuesday, the 18th of October. And it has in it a link, Stand Up for the Safe Step Act. And if you click on it for take action, you can send a message to your senators and representatives. But in my case, my representative has already signed on to this. And so just to the people who put this together, there should be a way where you could do this without sending it to all three, where you could just select ones you want to do it to. So that's just to pass on for whoever put this together.
I'm writing it down now, Stephen, and we'll talk to our VP of Government Relations and see if there is a way to parse that out.
Okay.
Michelle, I've got your notes as well. Thank you for the really good idea. Thank you.
Well, it's always so nice to see everybody, even when it's a smaller group. I love seeing all of you. But Katie, the next time we do a virtual conference, I hope we don't see you in a hospital bed again.
I really hope so too, Jane, because this is probably the second virtual conference that I've done from a hospital room.
Yeah.
And I'm kind of tired of this.
Yeah, I bet. Yeah. But the beeping stopped. Did they come in and fix your IV?
Yeah, they finally came in and fix my IV.
Good.
So we're not beeping anymore.
Good. Well, we really appreciate y'all coming to the conferences, both the virtual, in person, whenever you can do it. It's wonderful to see you. And I hope you all have a wonderful rest of your day and weekend.
Thank you, and the same to you.
Thank you.
For those who know me, I'm about to go kayaking. You're all welcome to rush over here and join me.
It'll be a long rush for three of us, at least. Thank you all.
All right, take care now.
Thank
Bye.
you. Have a good rest of the weekend.
Bye-bye.
Bye-bye.
Thank you,
Bye-bye.
Michelle.